For folks who didn't catch our last episode with Dr. Thomas Dayspring, where we focus mostly on the role of cholesterol and brain health, can you please remind everyone what area of medicine that you specialize in?
So I am a rare preventive neurologist. I am the first and to date only fellowship trained preventive neurologist. I did all of my training at Weill Cornell. I managed the Alzheimer's prevention clinic there for quite some time and built out programs for Lewy body and Parkinson's disease prevention. And now I'm full-time focused on this niche field of preventive neurology, which is really dedicated to helping people reduce their risk for diseases like Alzheimer's, dementia, Parkinson's, and Lewy body.
So are you mostly seeing patients who have early signs of some type of neurodegenerative disorder, or are you treating patients sort of very early in the process, well before any kind of sign presents?
So my ideal patient is someone who has risk factors for neurodegenerative disease, but doesn't have any symptoms of it. So neurodegenerative diseases are very similar to cardiovascular disease in that they form decades before in the body the first obvious symptoms develop. So you can learn that you're at high risk. Most people understand that based on their family history. They had someone in the family who had dementia or Parkinson's disease, or they did direct-to-consumer testing like 23andMe and found that they have a high-risk gene that predisposes them to one of these conditions.
So your interest lies in the prevention of the disease from occurring in the first place. Is treating dementia somewhat of a kind of different field of medicine?
It is a very different field of medicine, and that's because it really requires different levels of care. Of course, in the early stages, and maybe we'll get a moment to talk about the different stages of dementia, but of course, in the early stages of any neurodegenerative disease, symptoms are pretty mild and people are usually self-sufficient. But as the disease progresses, the needs of the individual often grow and they need help from occupational therapists and physical therapists and often social workers, psychiatry. So it requires really a multidisciplinary care group to take care of people once they've made it to the more advanced stages of one of these diseases.
And where are we at with regards to the science? Do we know more about prevention than we do about treating?
Absolutely not. I think that we are fairly new in the field of neurodegenerative disease, our understanding of neurodegenerative diseases, period, much further behind in our understanding of neurodegenerative diseases than we are in diseases related to heart health, much further behind. And in terms of prevention, like 10 years ago, people weren't talking about the prevention of neurodegenerative diseases. So this really is in the last 10 or so years that a lot more attention has been placed and a lot more recognition has been given to the fact that a large majority of cases of neurodegenerative diseases could potentially be prevented.
And you just kind of alluded to it, and we spoke about this in our last episode. Can you remind us of the kind of spectrum that neurodegenerative diseases occur on, what that looks like in terms of brain pathology and maybe how someone presents over time?
Right. So we often use dementia as an umbrella term for a lot of different conditions. When we're talking about neurodegenerative disease dementias, we're most commonly thinking about Alzheimer's disease, but also vascular dementia is very common, as is diseases like Lewy body dementia. There are other neurodegenerative processes like Parkinson's disease, for example, which don't always come along with dementia, but they can. I think that one issue of the field of neurology and the field of neurodegenerative diseases is that we're very segmented in the way that we think about Alzheimer's and dementia and the way that we think about diseases like Parkinson's and Lewy body. We have dedicated fields of movement disorders which study Parkinson's and Lewy body, and then these cognitive disorders are completely separate. And what we're learning more and more over in more recent times is that these diseases, there's a lot of overlap between them. When we start thinking about the pathology that is associated with these disease processes, for example, amyloid pathology is seen in both Alzheimer's disease and Lewy body dementia. And as clinicians, we really rely heavily on clinical symptoms to diagnose these conditions. But when we look at brain autopsies, we find that 50% of patients that were diagnosed with Alzheimer's disease have enough pathology to actually be considered Lewy body dementia and vice versa. And the same is true for things like vascular dementia and Alzheimer's disease. There's a lot of overlap there. And you can find tau pathology, which is often found in Alzheimer's disease and Parkinson's disease. So I think what needs to happen and the change that needs to be made globally when we're thinking about research in prevention is, instead of being in isolation as movement disorder neurologists or movement disorder researchers and cognitive disorder researchers, we need to think of these diseases on a spectrum and understand what the underlying pathology is in an individual, and then start understanding what drives those pathological processes.
So with that overlap that exists in terms of the pathology sort of underpinning different forms of dementia and Parkinson's, given that there is some overlap, in some ways, is that almost a good thing, because it means that there are kind of shared risk factors that you can address, and you can reduce your risk factor, your overall risk of developing any number of neurodegenerative diseases all at the same time?
Yes, which is what's so amazing about the field of preventive neurology. There are shared risk factors for these diseases. So that is what makes them prime for prevention.
Can you remind us what the difference is between preclinical changes and then when someone goes on to develop mild cognitive impairment?
Yeah, absolutely. I think this is really an important concept to understand. Of course, we have people that are at risk, and these are people who they don't have any clear underlying pathological process going on, but they may have a family history, they may have a genetic risk factor, but nothing obvious symptom-wise and nothing obvious in terms of biomarker positivity, which we'll talk a little bit more about soon. Then there's the stage of preclinical disease. And when we think about Parkinson's, it's prodromal disease, but it's essentially the same, which is it's silent. There are brain changes happening without any measurable symptoms. Sometimes individuals, patients may notice subtle changes, or they may have prodromal symptoms like new onset anxiety or mood changes that seem really off to them, but it's not clear to anyone at that stage that that's related to an underlying neurodegenerative process. Now that we have new tools to identify people in preclinical disease, and new tools are new blood biomarkers for neurodegenerative diseases, we can identify people in this preclinical stage, and maybe we can attribute some of these symptoms to preclinical disease. But classically, preclinical disease is silent. Then when we think about dementia, you progress into the mild cognitive impairment stage. And that's when cognitive symptoms are obvious. They're a concern to the individual, the patient, or family members. And it's usually involving one or more different cognitive domains. Things like short-term memory, things like visual spatial function could be affected, language, fluency. But in this stage, people are often still independent. They're able to drive, they're able to shower, bathe, do all activities of daily living. Once we get to the dementia stage, dementia due to Alzheimer's, dementia due to vascular dementia, dementia due to Lewy body, the main differentiating feature is that the cognitive changes are so significant that it interferes with an individual's ability to function in everyday life. They become dependent on others to carry out activities of daily living. And by that time, on a pathological level, there is such significant neurodegeneration or brain atrophy that that's what's impairing these cognitive abilities. And of course, we have increasing biomarker positivity dependent on what pathological process we're talking about.
What's the typical age where someone may experience preclinical neurodegeneration, and how would we know if that's something that we're experiencing?
It is so variable from person to person, but one helpful thing to think about on an individual level is if you have a family member that was affected by that disease, the typical age of onset of the family member is usually similar from generation to generation. It's not a perfect pattern, but it is something that we can kind of rely a little bit on to help understand potentially when that process could start. And, the preclinical or prodromal phase of disease can last decades, 10 to 20 years. So if someone, which, dementia usually starts in the mid 70s for people, if we're thinking about mid 70s, then sometime in someone's 50s, the symptoms could be starting in a preclinical stage.
And what are you seeing clinically when someone presents? You said earlier you're kind of getting to people early, but they have risk factors, and you want to address those risk factors. So, are you noticing a fairly kind of high risk where someone presents with a history of, say, high LDL cholesterol, high blood pressure, diabetes, things that we're going to talk about, the risk factors, that there's a very high chance when you look at these particular biomarkers you're talking about that you pick up that they do have preclinical neurodegeneration?
Sometimes they do. Just depends on the person. Of course, this is so inter-individual dependent, but yes, sometimes they do. And just to give a brief overview and about how we'll do Alzheimer's, for example, because a lot of diseases kind of follow similar patterns of neurodegeneration. We see a rise in a particular biomarker first. Often it's amyloid proteins when we think about Alzheimer's disease. And then, that period could last years and years before any other biomarkers become positive. And then we often see elevations in tau proteins. And once we see elevations in tau proteins, it's a good indicator that someone is really on the path to developing cognitive decline in the next couple of years. We start to see neuroinflammatory markers become positive, and then you see evidence of neurodegenerative changes.
And so if you don't intervene, there's a high chance, if you don't manage these risk factors and you have preclinical neurodegeneration, what I'm hearing is there's a high chance you could move through to this next stage of mild cognitive impairment and then potentially dementia. Would that be fair to say?
Yeah,
Okay.
that is fair to say.
And if you have a patient in front of you who has some of these risk factors, you do some testing, you notice that they have preclinical changes, and you intervene, and then you address some of these important risk factors and optimize them. Can you reverse that stage? Can you come out of that preclinical neurodegeneration, or will you just kind of always stay at that stage and hopefully not move forward to mild cognitive impairment?
Yeah, that's $1 million question and something I'm so motivated to research personally. This is part of the research that I do through the Institute of Neurodegenerative Diseases in Florida. But we hear a lot of people throw out terms like reversing dementia. And the truth is that by the time significant neurodegenerative changes have happened, brain tissue has been lost, it's atrophied. There's very little that we could do to bring back those neuronal connections or rebuild new neurons. It's not, we once thought that once a brain cell died, it was definitely never coming back. Well, we now know that's not completely true, but by the time you've made it to the point of dementia, we can do things to try to delay disease progression, and we can hone in on some modifiable risk factors, but we're not able to really reverse dementia. Could we reverse preclinical disease? That is a really interesting question that we don't have a complete answer to yet, but I can tell you based on the research that we're doing that we do find that giving people individualized risk reduction strategies and testing their biomarkers longitudinally, we've seen people improve their biomarkers for neurodegenerative diseases and in some cases improve them to a level where they were undetectable when they once were. Does that mean that we got them off the path of Alzheimer's disease? I really, really hope so. But the truth is we need decades of research in individuals like this over time to really understand what the trajectory will be.
So that's preclinical neurodegeneration. Is there any evidence at all that if you're experiencing mild cognitive impairment, what you went through before, this person's still independent, but they're having some changes to memory, perhaps, remembering words or where they're leaving things beyond what normal forgetfulness would be that we all kind of experience. Is there any evidence at all that you can intervene at that point in time and bring that patient back to an earlier stage where they're not having any symptomatic sort of memory difficulties at all?
I don't know about that. I will say that I don't know if we can normalize someone's cognition once they've gotten to the mild cognitive impairment stage. That said, I've had plenty of patients that I've seen that have come to me early with mild cognitive impairment, and we did all of the things that we should be doing, and we'll talk about all these things today. And we really honed in on all the known modifiable risk factors. And I've seen people at the advanced stages who kind of just lived their life and didn't really focus on things like optimizing their exercise and making sure their cholesterol and blood pressure were all optimal. And I can tell you clinically that there is a difference in the progression of these individuals. So I do believe that there's a way to slow down the disease progression, but I don't know if I can say that there's a way to bring someone back to a preclinical stage once they're already there.
Right, but take home message being that prevention earlier in life, presumably getting on top of these risk factors and just never getting to that preclinical neurodegenerative stage or mild cognitive impairment would be best. But if someone's already in these stages, still addressing these risk factors, even though it may not reverse, and it could, like you said, there needs to be more research. Even in the absence of that research, there's reason to believe that you could slow the progression, which would improve that individual's quality of life.
That's what I've seen clinically, and I truly, truly believe that. I don't think that it's ever too late for someone to start thinking about it. Even if they're in the mild cognitive impairment stage, it's not too late to start thinking about ways that you can try to slow down the disease.
Okay, so prevention. What is the best strategy or overarching kind of framework if we're thinking about preventing dementia and preventing these preclinical changes from occurring in the first place?
Now, with the Lancet Commission report on dementia prevention, intervention, and care, we do now understand that there are clearly at least 14 modifiable risk factors for dementia. And understanding what risk factors in an individual to really address is kind of the whole game and what I love to do for individuals and patients that I see. But we know, broadly speaking, that there are at least 14 levers that we can pull for any one person to help try to prevent or delay disease progression. And in 2017, when the first Lancet report came out, they found that 35% of dementia was preventable. And then fast forward 2020, 40% was preventable. And now in 2024, 45% of dementia is estimated to be preventable. And I think that probably still doesn't encapsulate all of the preventable cases that there are. I think as time goes on and more research is now invested in this area, we're going to find out that a large majority of cases is preventable.
How are we going at at addressing these risk factors at a kind of population level. I was interested in the report. I remember reading that at an individual level, it seems risk of dementia has actually declined, which seems positive. But overall, there are more people with dementia, kind of absolute numbers, because we have this aging population.
So yeah, I thought that was also such an interesting part of the report, and something that, we think of like, oh, we're not doing enough for dementia prevention collectively in the United States, in Europe, in Australia. We're not all doing enough. And it actually, in some ways, we've addressed some issues. Of course, we have tons of room for improvement, and that's the benefit of having big reports like this coming out to tell us ways that we can try to address issues from a public health standpoint. But when we think about less education, for example, that's a modifiable risk factor for dementia. It's an early life modifiable risk factor for dementia. It's something that I talk about and ask about with all of my patients. I am interested in what their educational background is. It is a really good proxy for someone's cognitive reserve, or how well bolstered up they are to withstand injuries, whether those injuries are related to head injuries, or whether those injuries are related to microvascular changes, or whether they're related to neurodegenerative pathological changes. Actually, when we think about what we've done in the United States, we've actually increased access to education for all kids. And that's probably a large reason for why dementia cases collectively have been on the decline. And of course, I'm sure there are people on listening to this podcast that are really a lot more invested in our educational system. And I'm sure it has its limitations and weaknesses. But in terms of access to education, we now have improved access. But it's not just access, it's also the quality of one's education. And what's really tricky when we look at large epidemiological studies is it's hard to really know the level of education and the quality of someone's education from place to place. And we know that that can drastically impact someone's education and cognitive reserve.
Is that cognitive reserve something that you think is built through exposure to learning stimulation as a kid? Or is it that people who tend to have more high quality education early in life, they go on to take up jobs that maybe are more mentally stimulating, and then that's building their cognitive reserve? And I guess the heart of the question is, if someone's 30 or 40, they can't really go back and change their early education. Is it too late, or can you build that cognitive reserve later?
So actually, I think the Lancet report looked at this. Maybe it's not in the Lancet report, but I read a study about this. So when we look at level of education and we think about people who have not achieved a very high level of education, but their jobs, their careers are very intellectually stimulating. And that's careers later in life, of course, after the brain is fully developed. We see that impact of low education is negated by having a really highly intellectually stimulating profession. So while level of education is a really great proxy for someone's cognitive reserve, it is just that. There are lots of other factors to consider when thinking about how well bolstered up is someone to withstand neurodegenerative disease changes. And it's always difficult when, you talk to someone, they're like, well, I can't go back in time. I can't go back in time and change the level of education that I have. But there are lots of ways that you can challenge your brain as an adult. And we do recognize that those things also build cognitive reserve, so they shouldn't be overlooked.
What are some of those activities or things that you might speak to your patients about that can stimulate their brain and build that cognitive reserve?
I really push novelty. Everyone wants a simple thing to do. And, we have Wordle. People love doing Wordle. So I'm like, great. I love that you're doing Wordle. It's wonderful. But what else do? Your brain gets very used to doing the same activity over and over and over again. So if it's not challenging to you, you probably aren't getting as much cognitive reserve as you can out of it. So change it up with what puzzles you're doing is always a good strategy. I like to have people, I'm an efficient person. So I like to give them efficient strategies to help with cognitive reserve, challenging them to take different types of exercise classes instead of, if they're a big runner, well, change it up. I don't know, do spinning that day or rowing. Like that's not really thought of as a cognitive stimulation activity, but it is because you're thinking about how to use your body in a different way. So I really challenge people to think outside the play a musical instrument, learn a foreign language. Just think about how you can challenge yourself in your everyday life that doesn't really interfere with what you're doing and just adds to it. Another thing I like to tell people to think about is reading, leisure reading. I am not the best at this myself because everything I read is all medical neurology related, which isn't probably doing a whole lot for my personal cognitive reserve, but challenge yourself to read different literature, different writing styles, different prose really helps build your verbal IQ, which is a different proxy for cognitive reserve, and one that we used a lot in our research.
Yeah, I'm the same. I tend to read studies that are published, or if I'm reading a book, it's nonfiction, it's on evolution or behavioral psychology or something. And so
Yes,
I
totally.
I know I need to start reading fiction.
I know. I tell myself my husband is so good at it. He's also a doctor, so we have the same like problems, but he's sitting there reading all these really fun, great novels, and I'm sitting here digging through neurology journals at night. So totally different.
Okay, so improvements in access to education may possibly explain why at a population level there's reduced risk, at an individual level. I suspect a reduction in smoking may also have an effect on that risk.
I would also agree with that, especially in the US, maybe not, you know what, I don't know so much about Europe, but every time I go there, I'm always flabbergasted by how many young people still smoke. It's wild to me. So like, please don't smoke. It's not good for your brain. It's not really good for anything. Yes, I think smoking is definitely a large factor for why dementia cases collectively have declined.
Yeah, I want to make sure we double click on smoking and perhaps touch on vaping at some point. Was there any of the 14 risk factors that you think might surprise people most or be the most surprising to people, risk factors that someone could easily overlook?
Yeah, I think so. This year, one new risk factor that was added to the report in 2020, there were 12, now we're 14. One new risk factor was vision loss. And this is something I have been preaching for forever. So I like to view the brain as a very use it or lose it organ. In 2020, we recognized that hearing loss was a modifiable risk factor for dementia. Now we understand that vision loss, uncorrected vision loss, is a modifiable risk factor for dementia. So there are probably lots of ways that both hearing loss and vision loss can contribute to neurodegenerative changes, but using this analogy of the brain as a very use it or lose it organ, it needs a variety of sensory stimulation to keep it happy and healthy. And one way that we get stimulation is what we were just talking about, cognitive stimulation. Very important, challenging your brain in new ways. But another way that we get stimulation to the brain is hearing. That is processed in a part of our brain called the temporal lobes, which is where Alzheimer's disease pathology often affects. And vision loss. So our vision is processed in two parts of the brain, primarily the parietal and occipital lobes. Those are regions of the brain that are impacted by Alzheimer's disease and regions of the brain that are impacted by Lewy body dementia. If you aren't able to see, you aren't able to hear, you're really depriving the sensory stimulation to those regions, and the brain needs that activation to keep it plastic, to help with neuronal signaling, to help maintain neuronal networks. So I think, as easy as it is to overlook things like hearing screenings and vision screenings, and maybe how annoying it may be to think about putting in a hearing aid or wearing eyeglasses or getting your cataracts removed, those things actually matter for your long-term brain health. And I think that probably will surprise a lot of people.
Yeah, I've worn glasses since I was 10, and then I transitioned to contact lenses. Untreated being the kind of key word from what you said there. So if you have poor vision, but you go out and get glasses or contacts, you've presumably eliminated that risk factor.
Unclear if it completely eliminates it, but it drastically reduces it. In the case of hearing aids, it seems like hearing aids cut risk in half, so it doesn't completely eliminate it. Vision may have better odds in terms of what correction does to ultimate dementia risk. Um, I think that, like this, people do skimp on their vision screenings, and we do think about what the eyes do in terms of visual acuity, but I also like to challenge people and this whole idea of like, what does visual stimulation mean for the brain? So, like, our eyes do so much more than perceive what's in front of us. They have to do things like judge spatial relationships, be able to focus on far things and then quickly focus on something close, be able to see a moving object and see it still and upright. And our eyes have little muscles around them. Just like any other skeletal muscle in our body, these muscles can become weak. So it's not uncommon for me to see people with various visual limitations. Sometimes they're born with things like strabismus or a lazy eye. And sometimes people do get that corrected early on in their childhood, but not always. And I think that what I've noticed in my own clinical practice is that people who've had visual issues in terms of visual tracking issues converging or focusing on an object up close, or they have a history of strabismus, they do have visual spatial issues, visual working memory issues. And whether or not that is part of the reason that they're more predisposed to developing a neurodegenerative disease later in life, I don't know, but I would expect that it is not helping. And it's something that can be addressed. So we think about, okay, let's put on our glasses, let's put on our contacts for visual acuity, but is there any way we can train our vision in a better way? Could we start using our peripheral vision more when we're outside, trying to perceive things in our periphery instead of right in front of us? Are we moving our eyes around? Are we focused just on our phone right in front of us? These things may sound silly, but I do think they matter long term.
Yeah, I mean, we may not even know the impact of phones yet, but I suspect the minutes and hours per day where a human is now focusing on text that's super close to their face has increased dramatically.
Totally. I mean, we aren't using our peripheral vision anymore. One thing I like to test when I see patients is put them in front of an eye chart and have them try to perceive the letters in their periphery without looking at them. It's insanely hard. I challenge people to try it themselves with a friend or loved one. It is so hard. We do have such limitations that I think we probably once didn't have when we weren't so focused on screen time.
Friends, if you're looking to sell products online, Shopify is where you need to be. Sure, you can list your product on various marketplaces today, but there's a big advantage to having your own e-commerce store. With Shopify, you're in control of your customers' data and can build direct relationships with your audience, which is key for boosting their lifetime value and scaling your business. Shopify makes setting up an online store an absolute breeze. It's designed not just for web developers, but for regular folks like you and me, making it easy to bring our vision to life with just a few clicks. Check out 38terra.com, an example of a site that Dr. Will Bolsowitz and I built using Shopify. Start by selecting one of 200 plus customizable Shopify themes, and then use the Shopify App Store to improve your marketing, store design, order fulfillment, and more. To get your product out there, boost your conversion rate, and grow your business, start today, right now, by signing up for a $1 per month trial at shopify.com/proof. That's shopify.com/proof. Hearing loss is something that I think most people, certainly me, prior to reading this report and speaking with you, I associated it with late life, but it was actually considered a midlife risk factor. What level of kind of hearing impairment are we talking about? Is it something that's so severe that the individual would be absolutely aware of? Or is this subtle kind of hearing loss that we would only become aware of if we went and did a hearing test, and perhaps we're not aware of it personally because it's developed so slowly over time?
Yeah. So when we're thinking about like the dementia risk factor, we're really thinking about more moderate hearing loss. So it's probably notable to people around you, maybe also you, but definitely people around you. But the truth is that mild hearing impairment turns into moderate hearing impairment in not such a long period of time. And the cause for hearing loss is often completely in our control. It's exposure to loud noises. So if you're a person who enjoyed loud concerts, like, are you wearing your hearing protection at concerts? Do you have hearing earplugs that you're wearing at these events? Are you someone who's exposed to loud machinery? It's not just the level of noise too. It's also the duration of exposure to that loud noise. So if you think about it as like, you're going to be outside and you don't want to get skin cancer, you got to put on your sunblock. The same is true anytime you're going to be exposed to loud or excessive noise. You should really be wearing hearing protection. And if you do know that you already have mild hearing loss, that's not a reason to go out and run out and get a hearing aid, because it's probably not really practical, nor is it probably really giving you a ton more benefit, but you don't want it to progress to a point where you need a hearing aid.
Right. So I think that's a really useful thing for people to think about, that it's that like area under the curve of exposure, intensity, duration, thinking about protecting your ears. Lots of us go to music festivals and concerts, and you see the odd person that's wearing concert grade earplugs, or at least I do. And, to be honest, I used to look at them and think, "What? That's strange. I wonder why they're wearing those." But now it seems like such a sensible idea if you're exposing yourself to that environment all the time, or perhaps you're a recording artist and you're in the studio. My phone, which I think is neat, sent me a kind of warning. There was a notification recently that popped up, and there's a setting in your phone, or at least on an Apple, where you can reduce loud audio, and you can limit the kind of decibels. Have you seen this?
Yes, I love this. Thank you, Apple.
Right. So it brought it to my attention for the first time that I'd been listening to too much music that was too loud. So at a certain point through the week, it was like, you've exceeded your safe, tolerable exposure to noise. And then I changed it down to the lower setting, which is like 75 decibels. And I haven't noticed a difference in terms of my enjoyment of music or anything like that. So that's a kind of like quick, neat trick for people that are listening to a lot of music.
I think that's really great. And I love that the new devices are now actually recognizing that we could be exposed unconsciously or unaware to these very excessive noises. And I also think, like going back to this idea, like I agree, like when you're young, you don't really think about like, oh, this concert's really blowing out my eardrums. But the next 2 days, you kind of have ringing in your ears. Like you probably did some damage there. And it seems super lame to be wearing earplugs to a concert, but there are really cool ones now, I promise. You can get ones with filters so that you can still have conversations with people and it's not completely muffled. You'll still be able to enjoy the concert. Your brain will thank you later.
And another common way where you can damage your hearing is diving and scuba diving. I went on a scuba trip to Socorro in Mexico. I think this was late last year. It was an unbelievable trip. If anyone gets the opportunity to go diving down there, there's sharks everywhere and dolphins and huge manta rays. It was unbelievable. Some of the dives were like quite experienced dives, and I was the least experienced diver. And so I was trying to keep up with everyone, and I wasn't equalizing as well as I should have been. And really, you need to take time and make sure you're equalizing on the way down, or you can really damage your ears. And after that trip, I didn't like blow out an eardrum or anything like that, but I was walking through a shopping center in Australia, and there was a lady standing out the front of a store, and she said, "Would you like to do a free hearing test?" And if I had that invitation at any other time in my life, I would have said no. But coming off the back of this diving trip, I was like, you know what? Actually, my left ear, I feel like it's a little bit off. Let's do this test. And my left ear in that test I had lost about 20% of my hearing. It's all come back. It's all come back since then. But I have to imagine that if I had have continued diving, continued not equalizing, going down too quickly, repeated exposure to that would probably accumulate over time, and maybe it wouldn't, return. And I actually have friends who have done a lot of diving, and their hearing today is compromised because of that. So I think it's kind of another activity where people need to be careful here.
Agree. I am a big diver. I've been on several scuba trips where people have ruptured eardrums, especially when you're in a place where there could be currents that really cause you to decelerate or go down quicker than you had intended to. It's something that you should be very careful of. And people who've had issues even in childhood with their eustachian tube, or there's a lot of scarring in there related to former ear infections, they're really just more predisposed to having difficulty with equalizing. So really take your time when you go down.
While we're talking about eyes and ears, perhaps we can quickly touch on the mouth. I know that poor kind of oral hygiene wasn't one of the 14 risk factors, but is there any evidence that you've seen that brushing your teeth or gum health or cavities are associated with dementia or increase the risk of dementia?
So yes, it wasn't one of the clearly identified modifiable risk factors for dementia. And I think that's because there just isn't a whole lot of research in this area that met their very vigorous standards of inclusion. So this is one that I think may in the future be added to the list. So of course, there's a lot more to learn here, but there is a growing body of evidence that certain bacterial pathogens, specifically these red complex bacteria, one frequent offender is P. gingivalis, which is associated with periodontal disease, can be linked to Alzheimer's disease and dementia. And there was one particular study where they identified P. gingivalis on autopsy in the brains of people with Alzheimer's disease. And how did this bacteria potentially get into the brains of people with Alzheimer's disease? We don't fully understand. What I can say and what I really think about this is whether or not these bacteria, because of their proximity in the oral cavity to the brain, and whether or not they could actually transverse the nerves and go to the brain, I don't really know. But I do recognize that there are people with poor oral hygiene and poor oral health, and that poor oral health is causing systemic inflammation. They're not brushing their teeth twice a day. They're not flossing. Maybe they're mouth breathers and they're changing the pH and the environment in their mouth that causes them to be predisposed to certain pathogens that could be problematic. Well, regardless of what it is, brushing your teeth and flossing is just such an easy thing. And I don't think that we should dismiss it. Whether or not it is directly the cause of dementia is really up for debate, but I don't think that it's something that we should be overlooking.
Yeah, even if it doesn't affect your brain, I'm sure your friends and partner will be thankful for introducing that daily habit. What about fluoride? Because often fluoride comes up in these conversations, or you'll see posts online and people will say fluoride is a neurotoxin. But then, dentists will advocate for fluoride as being good for preventing, gum disease and cavities. Is there any evidence that fluoride exposure from whether it's drinking water or mouthwash or toothpaste is good or bad for risk of dementia?
So I've heard about this and I've had a couple of patients send me some studies. I have to be honest, I didn't take a deep dive into this topic myself, but I haven't seen anything overly compelling about fluoride being super detrimental to brain health. And if there's anyone listening to this that wants to educate me and school me on it, I am totally open to that. But I have not seen anything overly compelling myself.
Well, that's a great response. And I mean, given that the Lancet report didn't include it as one of their 14 risk factors, it doesn't mean that it's not, like you said before about brushing your teeth and oral hygiene, but it kind of suggests that there is perhaps a lack of evidence right now to clearly state that this is a risk factor.
Absolutely.
We covered LDL cholesterol, which was the third risk factor on this list of 14 modifiable risk factors for preventing dementia in our last episode. And if my memory serves me correctly, in short, where we got to was that these low-density lipoproteins, they're not crossing the blood-brain barrier and getting into the brain. The cholesterol synthesis and transport in the brain is completely separate to systemic, but they can cause atherosclerosis in arteries that are supplying the brain with blood and nutrients and oxygen, which is one proposed mechanism that could explain why elevated LDL cholesterol is associated with higher risk of dementia. Is that right?
That's all correct. Well said. You were really paying attention and taking notes on our call.
So then the goal, I'm assuming, with your patients is to get their LDL cholesterol to some particular goal. Well, is there a goal that you kind of like to work towards? Maybe it depends on patient to patient. And how do you go about kind of talking to that patient about ways in which they can do that?
Yeah, so I hate to sound like a broken record in this conversation, but it is very, very person dependent. There are lots of different tools that we can leverage to really try to hone in on someone's ApoB or LDL goal. One thing that we can look at is coronary calcium scores. One caveat here when we think about brain health is that what happens in the heart doesn't always happen in the brain. So I've seen people with beautiful coronary calcium scans and significant microvascular disease on brain MRI. Why that happens, I don't fully understand. Could it be that it's just not driven by cholesterol and it's driven by other vascular risk factors that we're talking about? Sure, but I don't think that cholesterol is helping the picture. So if I do see somebody with evidence of microvascular ischemic disease on brain MRI, I want to be very aggressive in how I manage their vascular risk factors. There's no perfect target for the brain right now. We don't have the answer for what that looks like. So we have to depend on what we can learn from our colleagues in preventive cardiology and then make our own judgments based on the individual and what their brain looks like.
And are you mostly talking to patients about pharmacotherapy or nutrition or both? Putting aside the actual, I guess, target, and maybe the target actually affects how this conversation looks in terms of those interventions. But what's a typical conversation kind of encompass?
So I am an equal opportunist. I love lifestyle, pharmacology, supplements. I'm down for whatever could work. And I had been, I think classically misinformed of just how much diet could actually impact someone's ApoB and LDL. And even, I have to fight. Tom can listen to this podcast. I'm going to call Tom Dayspring out on it. But even Tom will tell me diet does not really move the needle in terms of ApoB and LDL cholesterol. And for most people, that is true. But I have had now, this is N of 3, but I'm still going to share these N of 3 stories because they were humbling. Patients that were, 2 of them were ApoE44s. One of them just carried an ApoE4, so high risk genetic risk factors for Alzheimer's and dementia that change cholesterol homeostasis and metabolism in the body. So specific people. And they were just so resistant to pharmacological therapies. And all three of them said, you know what, I've just been eating very poorly. I've been eating a ton of saturated fats. I've been loading up on carbs. I promise you, give me 6 months. I'm going to turn this around. Like, give me 6 months. And all three of them went from high ApoBs. I'm talking about ApoBs like 120s. And they all brought them down to ApoBs in the 60s, 70s. And I think that that's really drastic, like eye-opening levels of lipid lowering. And I think, what this is an example of is that ApoE4s just tend to be hyperabsorbers of cholesterol. So saturated fats don't do well with them, and they are absorbing more of that from their diet. I think that it also is easier to do that when you're younger. I think after years and years and years of high exposure, your body's just so efficient at recycling cholesterol, and it starts to recalibrate what its homeostasis is. So at those points, you really do need to leverage pharmacotherapy. But I will say that it is not impossible to lower your ApoB with diet, but it is very difficult.
Yeah, I mean, those are really big numbers. Typically what I've seen in the literature, there's a diet called the portfolio diet. You may have come across that, which was specifically developed to kind of lower LDL cholesterol. And typical LDL reductions on that kind of diet, if you're super adherent, right? So you have to be very, very motivated, because I think sometimes what perhaps is seen clinically is reflective of it's hard to adhere to a lot of these changes. So not everyone's going to. But if adhered to at a high level, the portfolio diet could kind of reduce LDL cholesterol by about 30%, which is less than what you've seen from those kind of, they're hyperabsorbers and perhaps hyper responders to dietary changes, like you said. But even a 30% reduction could still be quite meaningful. And I think Tom maybe is coming around, because I believe I saw him share a post recently where he was pointing people towards some nutrition dietary changes you could make that would lower ApoB. So I don't think he's totally against it.
He's not. That's not fair for us to say about Tom. He is a huge proponent of dietary interventions, but I do think that for most people, it's very difficult to closely adhere to a diet pattern that can be so restrictive for so long, which is fair. And for most people, due to this, the body's propensity to maintain homeostasis, even if you start eliminating how much cholesterol you're consuming, you do start just recycling the pool that you have. So it's just a battle that's very difficult to get at without some sort of pharmacotherapy.
And it's good for people to know that it might work for them. They can try it out. They can retest, and if it doesn't work for them, then they, understand that maybe they need to lean on pharmacotherapy a little bit more.
Yeah.
Depression was the fourth risk factor on this list of 14. How does depression influence the risk of dementia? Are there kind of proposed mechanisms that might explain that relationship?
So this one has been very fascinating to me. We published a Nature mental health paper on this and advocated for including mental health and emotional health as a part of our risk stratification for patients, because of this known risk, but also they also touch on anxiety and PTSD, which I think we should talk a little bit more about. What is really tricky with topics related to mood and mental health is that there's always a question of whether or not this is a prodromal symptom, a symptom of, not prodromal, but a symptom of dementia, or truly a risk factor for dementia. It is not uncommon for prodromal mood symptoms to occur in people who are at risk for dementia and Parkinson's disease, but it's also not uncommon for people with dementia or Parkinson's disease to develop anxiety and depression. At the end of the day, I believe that it is a risk factor for these diseases, and whether that's directly because, for example, in the case of depression and anxiety, we understand that there's maybe potentially this oversecretion of cortisol, which can lead to hippocampal atrophy, whether it's that or more likely, whether it's the fact that these diseases consume you in so many ways. They prevent you from being socially engaged. They start to interfere with your sleep. They interfere with your willingness to exercise. All of these other modifiable risk factors that they're affecting is probably related to that, but of course, unclear.
Is depression something that you would typically kind of screen for? You'd ask questions to kind of get a feel as to whether someone's being affected by anxiety or has depressive symptoms? And if so, and you find out that this person maybe has signs of depression, how do you manage that? What's the kind of evidence-based interventions that are available to someone to treat depression so that you can remove or sort of attenuate the risk that that's carrying in terms of their risk of dementia later in life?
So what was interesting from the Lancet report is that risk was lower for people with depression who were treated. And treatment could be pharmacology, could be psychotherapy, or combination therapy. So really, again, broken record, but really individual based. I really try to meet people at where they're at. From the Lancet report, we do understand that the point in life at which you may be struggling with mental health issues probably impacts your risk. So the earlier in life or the longer time period that you've had depression, the higher the risk of dementia later in life is. I think understanding what strategies and tools and potential pharmacology someone has tried before is important when understanding how to best address this. But I'm, at the end of the day, a neurologist, and I often rely heavily on help from neuropsychiatrists and regular psychiatrists and psychologists for help in this area. One thing that I think is interesting to bring up here, and the report didn't really go into pharmacotherapy in terms of like what pharmacotherapy may be the best for dementia prevention. We don't know the answer to that, but there is a growing body of evidence that actually is showing that certain SSRIs or selective serotonin reuptake inhibitors may actually reduce amyloid accumulation when they look at CSF or spinal fluid studies looking at amyloid deposition in the spinal fluid. People who are on these drugs have lower levels of it. So there may even be some drug repurposing that we may not need to use levels to treat things like depression, but we may, if someone has depression, want to leverage tools that may potentially impact dementia pathology.
That sounds very reassuring for someone that's perhaps listening and is taking SSRIs, and perhaps a space to watch. At the same time, I see comments online, and I can imagine a few people they're sort of hearing a red flag or an alarm bell's going off and going, is this just big pharma looking for another way to kind of monetize a drug and get another indication for it?
Yeah, I mean, you'll always hear those comments, and there's always a little skepticism about big pharma and leveraging medications for different purposes. But like when we're facing some diseases where our treatment options are so limited, I do think it's so valuable to study drug repurposing, because we do know that at the end of the day, SSRIs are safe and effective for people who really need them. There's a lot of stigma around treating depression and anxiety. And I think the conversation with people like us needs to be had so people could feel less stigmatized by it. And, sometimes it helps to package your treatment in terms of how do we help your brain health, and not necessarily how do we help address your anxiety or depression. Sometimes that just helps normalize the conversation.
And ultimately, we have to come back to evidence. It's very easy to leap to a conclusion or to judge something, but science is about scrutinizing the data, and then from there making the kind of best decisions that we're most certain about to help improve someone's health, in this case lower their risk of dementia. So that's a watch this space, SSRIs and risk of dementia. Number 5 on the list was head injuries. What's classified as a head injury?
Yeah. So classically, when we think about head injury, or people think about head injury, we're thinking about a concussion that was so severe it caused you to lose consciousness or have some sort of symptom afterwards, whether that was a severe headache or vertigo, nausea, amnesia for the event. But while severe head concussions are talked about and are a risk factor for dementia, even mild concussions or mild head injuries can increase your risk. And the concerning thing about head injuries is the younger that you are exposed, it seems like it could potentially be worse based on the report. We can talk a little bit more about that, but the more head injuries that you have, the more compounded the risk is. And, this is something that I think in America, the NFL is trying to be more aware of, with this idea of like the second hit and removing players that have had a head injury so that they don't get the second hit. But that second hit can happen, years apart, and it's that compounded exposure to head injuries that really is the problem.
Right. So we don't fully understand, if you suffer a head injury, like how many days or hours or weeks or months or years do you need to rest in between, returning to some type of contact sport?
So, there was a time in our training where we were told, after you hurt your head, you need to sit in a quiet room, turn off your TV, turn off the lights, and do absolutely nothing. And now we're sort of evolving past that and realizing that, as long as they're not exposed to another concussion, having cognitive stimulation is probably not that bad for recovery. It probably might help. This is really an evolving area of our learning, so more to be discussed on this topic in the coming years. But yes, you're right. What does that period of time look like before that second hit is really a problem? I don't think we know.
What's the main mechanisms involved here, do you think, that would explain why a concussion or a head injury is increasing the risk of dementia? Is it like literally the sheer force and like damaging blood vessels?
So lots of potential mechanisms here. Axonal injury. So our nerves have these really long axons, or long wires, for lack of a better word. And these are very prone, because of the length of them, to shear forces. And that injury can promote proteinopathies. So can promote phosphorylation of tau proteins, can promote deposition of amyloid beta. It also triggers the microglia or neuroglial activation. And then that can lead to neurodegeneration, cortical atrophy. Of course, as you mentioned as well, there could be injury to the small blood vessels in the brain. And we can sometimes see that on brain MRIs in people who've had multiple concussions with no vascular risk factors.
You mentioned before that a head injury doesn't necessarily need to be a full-blown concussion or loss of consciousness. And I remember reading a while ago, and I believe there was some commentary on this in the report, that some soccer leagues have banned headers because people who are heading the ball more regularly are at a higher risk of dementia. And that really stood out. That really surprised me because, again, evidence that it doesn't mean you have to have this severe head trauma where you're unconscious and kind of black out, that a more subtle kind of whipping your head just into a soccer ball could be causing enough damage.
Yeah, you're absolutely right, Simon. And I think what, to me, this really begs for is most people who, and it's soccer and rugby, and I think football were the big ones, North American football. I think what this really forces us to think about is, people who start these or who engage in these sports often began their engagement with them in childhood. And what I think we need to start thinking about is what we choose to engage in and what we allow our children to engage in. If we understand that someone has a really significant family history, a long family history of neurodegenerative diseases, or we know that, we carry a high risk gene, really carefully thinking about what extracurricular activities you want to sign your kid up is really probably something we should be thinking about. And, we can't leave it up to things like the NFL to decide whether or not they want to disclose these inherent risks of the sport to the people that are so engaged and that's their profession. But I do think educating people who do play these sports that this is a risk that you may face later in life is just really so important.
What is it about the kind of young or developing brain that makes it more susceptible to either damage or setting you up for dementia later in life? Is there like an anatomical explanation for that the kind of skull or head is just not as well protected, or is it because you're influencing development in some way by having that head knock?
Yeah, your guess is as good as mine there. I really do not know. And I found it very surprising that it was men and young age seem to be the people who are most vulnerable to the negative impacts of head injury and concussion, while men are maybe more exposed to those risks. And so are people in younger age. One thing that I've seen in my clinical practice, so I love doing a deep dive in family history and really understanding what or how someone's family member developed dementia. And a common story that I'll hear is my mom or dad was fine and they had a fall, they hit their head, and then it seemed like everything went downhill from there. That's when the memory started to go. And it makes me wonder if we're just seeing a little bit of a biased sampling when we're looking at the types of people included in these studies, or if it's truly an age, gender, biological sex difference.
Yeah, young males, I'm not sure that surprises me that much. Now when I open up Instagram or on the very rare occasion TikTok, it just seems to be younger boys doing crazier and crazier things, jumping from building to building or crazy cliff jumps and, trying to outdo one another. So I think young males are just inclined to kind of take more risks.
Us boys will do dumb things.
Yeah. I actually have a friend who he was talking about having kids, and he's like, listen, for the first few years of their life, particularly if they're young boys, just remember, they're just like trying to kill themselves. Your job is to keep them alive.
Yeah. You're walking around constantly taking scissors out of their hand. Like that is just part of it.
Let's talk about a game changer in the world of sleep technology, 8 Sleep and their revolutionary Pod 4 Ultra. While nutrition and exercise get a lot of the limelight, there's no denying that both of these are incredibly hard to do well if we aren't getting a good night's rest. If there's a weak link in my own lifestyle, it's definitely sleep. Those deep 8-hour slumbers are nowhere near as frequent as they used to be. Lately, I've been making a concerted effort to upgrade my sleep. A big part of that included the 8 Sleep Pod 4 Ultra, which is a high-tech mattress cover that transforms your existing bed into a sleep optimization powerhouse. It's equipped with advanced technology for precise temperature regulation, elevation control, and comprehensive biometric tracking. The temperature regulation is my favorite feature. 8 Sleep's autopilot uses machine learning algorithms to analyze your sleep patterns overnight and automatically adjusts the mattress temperature between 55 to 110 degrees to help initiate and maintain sleep, as well as optimize the stage of sleep that you're in. When you wake up, the 8 Sleep app provides you with an overview of your sleep quality and important health metrics like resting heart rate, HRV, and breath rate. Since using the 8 Sleep Pod 4 Ultra, not only do I feel more rested and energetic, but I've also noticed my heart rate overnight has lowered by about 5 beats per minute, a sign of better recovery. Ready to take your sleep and recovery to the next level? Head over to 8sleep.com/theproof and use the code THEPROOF to get $350 off your very own Pod 4 Ultra. The best part is that you still get 30 days to try it at home and return it if you don't like it, but I'm confident you'll keep it. Trust me, your body will thank you for this investment in better sleep. Shipping to many countries worldwide. See details at 8sleep.com/theproof. I saw recently, and maybe you mentioned this, but it kind of is related to NFL. Brett Favre was diagnosed with Parkinson's. You might have mentioned that in our last episode. So do you think that is that just a coincidence, or are head injuries also a risk factor for Parkinson's, not just dementia?
Yeah, so this really goes back to what we were talking about at the very beginning of the episode, where these neurodegenerative diseases do have shared risk factors. So head trauma is absolutely a risk factor for Parkinson's disease. Is it a risk factor for idiopathic Parkinson's disease or something called CTE? It's probably a risk factor for both. Hard to really know in vivo what Brett Favre has. Does he have idiopathic Parkinson's disease? Does he have CTE? At the end of the day, he has Parkinson's disease clinically. And that is, in my opinion, a consequence of his exposures with his career.
I take it you're probably not a big fan of the UFC. Have you watched much of that?
I haven't watched much of it. I try to avert my eyes anytime I see people doing bad things to their brain. So no.
Yeah, there's a lot of fists and elbows and knees to the head. Hopefully we don't see a bunch of kind of ex-UFC fighters developing dementia in decades to come, but I have to think it's heightening risk. If you were someone who had a lot of concussions, so in your 20s, in your 30s, maybe now you're midlife, so you're in your 40s or 50s, and you're thinking, gosh, I wish I listened to Kellyann, had have come across this information that Kellyanne's sharing 20, 30 years ago. They're worried about developing dementia. What would you do if you were them?
Yeah, so of course we can't undo the damage that was once done, but we could do a lot in terms of addressing our other modifiable risk factors. So for anyone that's listening on this call, please listen up to all those other risk factors that we were talking about, like hearing loss, vision loss, cardiovascular risk factors, exercise. There's things that you can do now to try to offset some of this inherent risk. It's kind of like understanding that you carry a high risk gene. Well, you understand that you've had some high risk behaviors that you can't really undo, but you can take steps to try to mitigate any further injury. And for these people in particular, my advice to them is really to take a close look at your exposures to head injuries in your life now. Every time you're in the car, you better be wearing a seatbelt. If you're skiing, okay, I understand. Love the skiing, love the snowboarding, but those are really high risk activities. Please wear a helmet if you're partaking in these activities, or just do a deep dive in terms of what things are so important to you in your day-to-day life that you are not willing to compromise on because they bring you so much joy. I'm all about that, but understanding what additional risk it may lead to had you fallen or injured your head is really something you have to think about.
Right. So mitigating risk as much as possible. And presumably, if you're someone that's had those concussions in your 20s and 30s, it might just give you a little bit of extra motivation to kind of get through and optimize as many of these 14 risk factors as possible, hopefully.
Absolutely.
You mentioned exercise, which brings us to risk factor number 6. What is it about exercise or physical inactivity, not doing exercise, that is so bad for the brain and risk of dementia?
Yeah, I mean, lots of things to talk about here. And I'd have to say another poorly researched area of medicine, period, because what are really the incentives to studying exercise? Like, who's funding these research? But one thing that we think about what does exercise do? I mean, there's so many different types of exercise. There's high intensity cardio or exercise, there's strength training, there's balance and mobility, there's moderate or light cardio exercise. So all of those different types of exercise could potentially do different things for the brain. We do know that moderate to vigorous exercise seems to increase brain volumes, or at least are associated with increased brain volumes, whether that's through increasing blood flow to the brain, through increasing nitric oxide and blood flow delivery to the brain. That's probably one potential mechanism. But we also understand that when we exercise, there's lots of different neurotropins that are released that promote neuroplasticity. So we talk a lot about things like BDNF, another myokine called irisin, which is also known to be neuroprotective. There's probably so many countless mechanisms by which exercise can help the brain. And I truly believe it's one of the biggest levers that we can pull.
What's a myokine if someone's hearing that for the first time at a kind of high level?
So a myokine is a chemical that is almost like a hormone that can help communicate between muscles or skeletal muscles. It's released in response to a muscle contraction, and it can have effects on other organ systems. So, for example, in our case, we're talking about the brain, so can impact brain function. And irisin in particular helps with synaptic plasticity, or the connections between brain cells, how willing they are to withstand changes to their environment.
I mentioned before that I read some kind of evolution science books, and I remember coming across this theory that I think is related here. I guess taking a step back, probably when people think of exercise and dementia, immediately you think, well, exercise will help with body weight and blood glucose control, risk of diabetes, like these other things that we're going to talk about. But what you're saying is there's these direct effects kind of in real time that are occurring, that occur when you move your body on brain physiology. And I remember coming across this explanation, and it was talking about like brain-derived neurotrophic factor and these different kind of peptides being increased in the brain that can improve neuroplasticity and learning and memory. And perhaps the evolutionary explanation for this is that would help people remember when they were out moving, running to get food, to find food, or to get away from predators and find safe locations. It would help you remember those locations. So you can get calories and energy and safety, the things that ultimately help you survive and then procreate.
I mean, that would make sense. And just to add on to this whole theory, if we think that BDNF is really something that is prominent in the hippocampus, and high levels of BDNF promote neuroplasticity in the hippocampus, that's our memory center. Things like sense of smell, which evoke these strong feelings of nostalgia and emotion, also feed directly into the hippocampus. So you could kind of see how that evolutionary idea might hold true.
Yeah, that gets me thinking about smell now as another sense. And maybe this hasn't been researched at all or enough. But I wonder if stimulating our brains through exposure to different smells plays a role in kind of cognitive capacity.
Well, there's definitely a body of evidence on this. So if for people who are interested in like cheat codes for studying, they have things like, when you study, you should sniff lavender, because then when you're trying to recall that information, you can sniff the lavender again. It'll help you pull the information out of memory. I've not tried it. I don't know anyone who's tried it, but if anyone's interested in trying it, please report back on how well that worked out.
What's the best form of exercise you think for preventing dementia? I'm not sure whether you can answer that specifically or not, and perhaps you could, if you feel okay with it, sort of explain or share with us what an ideal week of exercise looks like for you.
Yeah. Again, broken record. I don't think that we know what the optimal duration, intensity, and type of physical activity is, period, for the brain. I really don't think we understand that. What I do think was very interesting and eye-opening is that when we think about exercise or physical activity in respect to what the Lancet publication is talking about, one of the greatest improvements was someone who went from completely sedentary to some physical activity, which I think was defined as something about it's something very small, like 3 days of like light walking. That is so eye-opening, because I know a lot of people that are listening to this, I'm included on that, are just like healthcare optimizers. And we think about like, how do we incorporate our strength training, our zone 2, all these things into our week? Just knowing that any little bit of exercise that you're doing is going to help the brain, I think makes this idea of exercise a little bit more digestible for people who really don't enjoy it, because I do understand that there are a lot of people out there that don't enjoy exercise.
Yeah, that's really motivating, and that lines up with, I've looked at research looking at cardiorespiratory fitness and just total mortality, and you see the same thing. The biggest reduction in risk of premature death occurs when you go from sort of very, very low cardiorespiratory fitness to sort of like below average. It's just getting in, and I've seen some researchers try and sort of quantify, how much movement is required. And one paper that I'm thinking of, I can put in the study notes, suggested that it might be around 150 minutes of moderate intensity exercise, which is going to look different. Like you said, that could be slow walking for one person. It could be brisk walking or jogging for the next person, but 150 minutes of that a week to kind of get from very low to like average.
I also think what was interesting in the Lancet report was that, and this kind of goes back to this question of like, what is an optimal exercise routine regimen program for preventing dementia? Well, they pulled some study that looked at an individually estimated optimal physical activity level. And that was associated with the largest reduced risk for dementia, compared to giving someone a protocol of, for example, 100 minutes of moderate intensity cardio per week. And I think that really goes back to this idea of like, what is exercise really doing for us? I do think one major thing that it's doing is helping mitigate some of these other metabolic risk factors and cardiovascular risk factors like insulin resistance and high blood pressure. And when I see a person and I try to do body composition and DEXA measurements on them, and I look at various blood biomarkers and try to really understand, like, is this person somebody who has evidence of insulin resistance? Because if that's the case, they're probably under-muscled and probably need to get their muscle mass up, because we understand that our muscles are kind of our glucose sponges, and they're out there absorbing glucose from our bloodstream and can really help with insulin resistance. When I think about someone who has really high blood pressure, I actually do think about things like higher intensity cardio training for them based on the studies that I've seen. But it's really an individual mix for most of the people that I see. And I'm even a little bit out there in terms of, as I mentioned, I like testing different sensory inputs to the brain. So I like understanding someone's visual system and their peripheral nervous system, and I like understanding their balance. I think that challenging our body with our exercise program is what's really key. So I love telling people to exercise outdoors because I really think that that increases your visual stimulation. It makes you a little bit more aware. I like incorporating balance work in people who do have really poor balance and don't have very good proprioceptive awareness in their extremities. I think that's probably beneficial, but all of this is my personal opinions and something that I think will be really, really hard to study in any vigorous way and with very little incentive to do so.
But it makes sense mechanistically. I mean, earlier in the episode, you mentioned novelty when it comes to learning. And it could be a similar thing here, that diversity of exercise and novelty where you're continuing to challenge yourself. Because when you're exercising, you're having to use your brain in a number of ways, might be really important. And then also in certain circumstances, exercise is not only impacting those cardio kind of metabolic risk factors, but one of the other risk factors in this list was social isolation. And not in every setting, but certainly in many, if you think about like run clubs or playing pickleball or playing tennis, there is a strong social element to the movement, either during the game, but often afterwards people are hanging out or they do social events with, the club because everyone becomes friends. So there's some kind of, I'm sure, some relationship between certain types of movement and loneliness, social support, these types of things.
One of my favorite recommendations for someone, especially someone who isn't big into exercising, is group fitness classes because of that aspect of social engagement, but also the accountability of it. I think it's so important to find something that's going to stick. But I also think, the challenge that you get with exercising with different people and that motivation is just so powerful.
While we're talking about relationships and being with other people, it probably makes sense here to tackle social isolation, loneliness, which was one of the risk factors. What do you think it is about having interactions with people that care about us and that we care about that is helpful when it comes to preventing dementia? How would we kind of explain that, do you think, from a mechanistic point of view?
Well, I think that there's probably some component of this that does tie back into this concept of cognitive reserve and building cognitive reserve. Lots of different ways that we can build cognitive reserve in our social support and social interactions. And honestly, emotional intelligence, or EQ, probably does feed into our cognitive reserve. But having strong social ties also does help promote healthy behaviors. Again, tied back into this concept of, group fitness, it's holding you accountable, but also just helps you maintain these healthy behaviors in your everyday life. And then I think that there's probably a large component of that social support providing stress reduction and providing that emotional connectedness and promoting your emotional health that could be so beneficial. One little comment is this differentiation between what social isolation is and what loneliness is, because yes, they're related, but they're also different. So social isolation defined as living alone, seeing friends or family less than once a month, or participating in no group activities a week. Loneliness is really that feeling of social isolation. It differs because it's truly about one's perception of feeling alone, and they're distinct and separate. So both are associated with an increased risk for dementia. So it's not just not having the social connections, it's also your own perceptions of that, which probably heavily ties into someone's feelings of depression and anxiety as well. But I did find that really an interesting distinction that I think is notable.
So the person who is socially isolated, but if you ask them, are you feeling lonely? They say no. What you're saying is, even though they don't feel lonely, the social isolation on its own, if I heard correctly, is enough to increase the risk of dementia, presumably because they're still not getting that stimulus that comes with conversation and listening and supporting and helping like solve problems between people that occurs when you're with friends and with family members.
Yes, you nailed it.
In your experience working with patients, what do you think are kind of some of the most helpful tips for helping people reduce social isolation?
So one benefit that I think the pandemic has brought is that it has connected us a little bit more to each other. And while there's probably a difference between in person and virtual connections or distant connections, we do recognize that there are people for various reasons, especially people who are older, who can't really get out and have weekly meetings with people in person. The ability that to now easily connect to people with shared interests or family members, loved ones throughout the world, I think this is super important. So while there's lots of problems with the internet and being hyper focused on the internet, I think for some people that is really an important way to be socially engaged. The other thing that I want to say here is, we'll spend some time talking about women's brain health, but in this case, this is really relevant to men's brain health because men are just more vulnerable to social isolation. They are classically known to have deal friends and not real friends. So women, for better or for worse, are just better at maintaining relationships throughout their lives. And men tend to be more focused on their profession and kind of ignore social relationships and feel awkward about reaching out to people and having friendships with people. And what happens when, in older age, when their spouse dies, is that like their whole social world falls apart because it was very dependent on the woman. So for men, forcing them to reconnect with old friends and having, dinner dates or like whatever sports dates, whatever it is that puts them in connection and helps them bond, game nights, whatever it is, helps them bond with friends is so, so important.
Diabetes was risk factor number 7, and close to that were hypertension and obesity. I'm not sure whether it makes sense to step through those 3 separately or all together. Feel free to kind of tackle them however you'd like.
Yeah. So let's talk about diabetes I think it deserves its own spotlight. So yes, it's a risk factor for dementia, cognitive decline. Again, I know it's not about Parkinson's disease, but shared risk factors. It's also a risk factor for Parkinson's disease. And when we think about diabetes or insulin resistance, really what is problematic, and this also relates to high blood pressure, is when glucose control is erratic. So there are frequent episodes of hyperglycemia and there's not a lot of stability in our blood sugar. We also understand that poor blood glucose regulation speeds up cognitive decline in people already with mild cognitive impairment or dementia. And related to that, high blood pressure, which is something that I think also deserves its own spotlight in a moment, but erratic blood pressure control is also linked to accelerated cognitive decline and an increased risk for dementia. So, being stable and understanding what our glycemic control is really difficult because the most common tools that we use, at least as doctors, are things like hemoglobin A1C, which gives us really a rudimentary understanding of our blood glucose control over the last 3 months. And we can look at someone's fasting glucose and fasting insulin levels, but there are limitations in that. And we may miss some opportunities there to really hone in or optimize our insulin control or insulin sensitivity.
What are your views on using CGMs? Are they something that you use in clinic with a particular patient?
So on case by case basis, I find that some people don't do well with numbers and lots of data. And I also don't think that it's the right tool for everyone. I think that there are people who are predisposed to disordered eating, and certain eating disorders that I think giving more tools like this can actually do more harm than good. But I do think for a lot of people, it can be a really helpful tool to understand dietary patterns and how your body reacts individually to different foods. I don't think that it's something that you have to wear all the time. I think that you can get a lot of education from it in a 2-week period, and that can really inform how you approach your diet on an individual level.
I've seen kind of mixed opinions out there. You'll see people that are crazy against CGMs, people that are crazy for them. And ultimately, I think like what you just said there sounds like good advice. It's going to work for some people, it might not work for some people. I guess for the people that it works with, I wonder about the education, the kind of instructions that they might need in terms of how to interpret it, right? Because I think from someone with a nutrition science background, I have a little concern where if the goal is to completely just flatline glucose, I could make a number of changes to my diet that we might say are overall net negative food replacements, but lower blood glucose. So is that something, how do you navigate that? Is it just giving people some overall dietary advice and using the CGM?
Yeah, I think that's exactly right. I think it's about, it's not about, to me, flatlining someone's blood sugar, because there could be, helpful blood sugar spikes. We know that after exercise, and you could have a brief blood sugar spike, or when you first wake up in the morning, there could be a brief blood sugar spike related to cortisol. And those things aren't necessarily, quote, bad, right? So I think changing our conversation around it is important. But it's not about flatlining it. It's really about, these are scenarios I find it most helpful in. There are people who make, these amazing smoothies and shakes, and they think they're like loading it with all these really helpful things and wonderful things. And then, after they drink their smoothie and they see that their blood sugar is spiking to nearly 200, when it's like, in the baseline 90s. I think that that's really educational, because it helps them understand perhaps things that they viewed as, and I'm also going to give a caveat, in the right setting, in the right person. So someone that we already suspect may have issues with insulin resistance or poor eating habits, to see that in real time, I think can really help, because there's a lot of, quote, health foods that are not actually that healthy for you. And I think it's helpful for you to see that and to understand how that may be responding in your body.
Right. I hope someone makes a device that at the same time can give you your ApoB.
Right? That would be very cool.
I mean, because it's not like our food is just affecting one marker in isolation. There's lots of different changes. So it'd be cool to get real-time feedback on blood lipids, real-time feedback on blood glucose. And then that might make it even easier for people to kind of make healthier food choices.
I think so. I mean, there's no perfect way to help when it comes to dietary interventions. And also there's no perfect way to understand. I think this is really a huge, you could talk more about this than I can, but I'm sure we agree that this is just a huge area of improvement for us as medical providers to really understand. There's no one size fits all for nutrition. And it's so challenging to educate people on what is a healthy choice for them.
How do you assess kind of risk of developing diabetes? I mean, you mentioned earlier, you sort of spoke about HbA1c and fasting glucose. If someone's listening right now and thinking, I'd love to just understand, what's my insulin sensitivity? Do I have prediabetes? Do I have type 2 diabetes? What does that look like in practice for you?
Yeah. So of course, hemoglobin A1C is such a widely used metric that I do think that there's some value in understanding what it means and understanding potentially what optimal looks like for brain health. But we understand that it has its own limitations. And at the time that hemoglobin A1C may be abnormal, we may be missing the boat because something could have been happening earlier. One of the challenges with this Lancet paper and a lot of research in diabetes as a risk factor for dementia is that it's truly defining this as diabetes, right? So we're talking about high hemoglobin A1C levels. We're not talking about insulin resistance or quote pre-diabetes. We're talking about clinically, you meet the clinical criteria for diabetes. Ways that I like to leverage understanding someone's insulin sensitivity is a terrible test called an oral glucose tolerance test. And that really is because it helps us understand someone's insulin response. Are they over-secreting insulin in response to a glucose load or not? And that does have some correlation to overall likelihood of developing diabetes later.
And if someone presents to you with diabetes, what's your kind of general approach to treating diabetes to lower their risk of dementia?
This is a really amazing, interesting topic, and I'm so glad we're spending some time talking about it. So I always like thinking about what drugs, there's no one focused on this, right? There's no one focused on what pharmacological therapies are best for brain health. We understand which ones can help diabetes. We understand which ones can help high blood pressure, but are there ones that are better for the brain because they have secondary effects that directly relate to the brain, or because they penetrate through the blood-brain barrier and can have a direct impact on brain health? So this, again, not highly studied, but there was one study that looked at various drug classes and found that SGLT inhibitors and GLP-1 agonists probably are associated with the lowest risk of dementia. So a good option for a lot of people, whereas things like sulfonylureas may actually be harmful for brain health. Of course, we need more studies there, but I just thought that was so fascinating and helps really give us an understanding that, there may be an optimal treatment approach for those people who do have diabetes, and maybe we should be thinking about specific drug classes.
Yeah, that's super interesting to think about in the context of GLP-1 agonist and obesity. So recently, obviously indicated for obesity. And I've seen, various people online say, okay, great, they're helping people lose weight, but maybe they're increasing risk of dementia. And what you're saying here is, or what's interesting is that GLP-1 agonists, to my understanding, have been indicated for type 2 diabetes for quite some time. So presumably you're speaking about long-term data of people with diabetes that use a drug like GLP-1 agonists, like Ozempic, they have reduced risk of dementia.
Yeah. And this is something that I'm personally very interested in our research. So when we test these various blood biomarkers for neurodegenerative diseases, we try to isolate or start one drug at a time to really understand, is it a statin? Is that helping this person? And we have no pharmacological disclosures to release. We just want to know for our patients, what drugs should we be using? So yes, and this is something that we've seen in our own clinical practice, that very careful, and I want to triple emphasize, bold, highlight, underline, italicize, careful use of GLP-1 receptor agonists actually reduces phosphorylation of tau proteins in people with preclinical disease. This is what we've seen. It's not yet published yet. So hot off the press from our research, but and this is a small sample size, so we need a lot more people. But in some of the mouse models, looking at what GLP-1 receptor agonists do, that is something that it was shown to do, as well as reduce neuroinflammation. It could reduce amyloid deposition. We haven't seen that as much, but this is a huge, huge area, I think, of opportunity. But again, I want to come back to careful use. I think that when used incorrectly, you really do risk more harm than good. I do very much worry about loss of muscle mass in people who are on these drugs because of all of the things we already talked about with the importance of maintaining muscle mass in terms of brain health. So it really, really has to be carefully watched and monitored to make sure that you aren't crossing over that line where more harm than good is being done.
Right, and hopefully occurring sort of, side by side, a good resistance training, eating enough protein, doing pulling these various levers that we can to preserve muscle mass as someone's lowering their body weight. The evidence that suggests GLP-1 agonists might be protective against dementia, is that compared to someone with diabetes that's not taking a GLP-1 agonist, or is that just compared to someone without diabetes?
Yeah, it's compared to untreated diabetes. So when that one study was looking at different classes of medications in people with diabetes compared to untreated. So of course, issues there, and there probably won't ever be a perfect study on this because so many complicating factors. But yeah, and this is also the other challenge when looking at like these drugs and using these drugs in people who potentially don't have diabetes, right? They just have pre-diabetes. Like, should we be using these drugs in those people? When do we start to turn to pharmacotherapies versus pulling on lifestyle levers as much as possible? Like, what is that decision and what does that look like in an individual person? These are the nuances of preventive neurology.
Right, which is a similar conversation to when should you start, lipid lowering therapy? Is primary prevention, is it indicated in people who are just at risk, or is it just indicated in people who have had events? So it's like we've been through all of that before in a different area of science, a different risk factor. So, hopefully with continued science, we kind of get there with all of this stuff. If someone's diagnosed with type 2 diabetes and then manage to get them into remission with the help of you with sustained weight loss, perhaps they're using a GLP-1 agonist, perhaps they make dietary changes with that as well, they're exercising, are they still at increased risk of dementia, or what happens to their risk?
It seems like their risk is negated if we can eliminate their diabetes, but this is something that I think is still evolving and we don't have a perfect answer to.
Obviously, obesity is related to diabetes. Not everyone with obesity develops type 2 diabetes, but most people with type 2 diabetes are overweight or obese. Talk to us a little bit about obesity separately as a risk factor. How does excessive body fat influence risk of dementia? Is it just by affecting these other sort of traditional risk factors that we're thinking about, like insulin resistance?
So, irrespective of insulin resistance, diabetes, high blood pressure, and physical inactivity, obesity in midlife is a risk factor for dementia, which is really an interesting thing to think about because it makes you start to think about, well, what is it about having high adipose tissue and specifically visceral adipose tissue? What is it about it that's influencing our brains? And it's probably related to pro-inflammatory effects. So another area that I'm really interested in is neuroimaging, and what we see when we look at brain scans and correlate brain volumes to visceral adipose tissue is that people with higher visceral adipose tissue have lower brain volumes in key regions of the brain impacted by Alzheimer's disease. It's probably, in my own hypothesis, it's probably related to this spiral of inflammation that happens when there's a high visceral adipose tissue load.
How do you help patients achieve a healthy body weight? What does that framework look like?
So, one study that they highlighted in the Lancet Commission was that even modest weight loss, which was defined as 2 kilograms in a specific trial, was associated with improved cognitive function at 6 months, even if the weight loss wasn't sufficient enough to alter the diagnosis of diabetes. And this benefit was most pronounced in those people who changed their diet or exercised, and was not found in people who undergone weight loss through things like bariatric surgery. So I think that is also in itself so interesting. Like, is it, why don't we see, with just reduction in total body fat, like why don't we see that same benefit in terms of cognitive function? Why is it that the weight loss that comes along with physical activity and diet is more impactful than just the sheer shedding of pounds?
Okay, let's hit hypertension. It's been mentioned a couple of times. What is hypertension, and roughly how prevalent is this in a country like America?
So hypertension, we're talking about high blood pressure, defined by the Lancet Commission as a systolic blood pressure of 130 or higher. That is probably not the right definition based on a lot of other studies, I will say. So the Sprint Mind study actually looked at a systolic blood pressure of 120 or less, and that was associated with more profound cognitive benefits than a goal of 130 or less. So I'm throwing that out there. I'm gonna be ignorant here. I don't know what the prevalence of high blood pressure is in the United States, so fact check me on that one.
According to the CDC, the prevalence of hypertension in the United States among adults aged 18 and older was 45% in 2017.
Wow, that's higher than I actually thought it was.
Yeah, so that probably makes it one of the most prevalent risk factors in this whole list.
Yes, totally. And something I read about recently was actually, and this sort of does tie in because we're going to talk about drugs here. So 80% of stroke is preventable. And they came out with these guidelines on how to prevent stroke. And one thing I thought was so fascinating was that most people aren't controlled with their blood pressure on one agent. So they need 2 agents. Most people, they are found to have high blood pressure. Their doctor starts them on something and they never really check their blood pressure ever again. We just assume that we treated it to a sufficient level. And again, the definition of sufficient is debatable. I think 120 or less is much better, much more optimal, but not even getting to the goal of 130 or less.
Is low blood pressure a risk factor? When does it get too low?
Yeah. So it does seem like there's a sweet spot for blood pressure. While lowering systolic blood pressure does reduce dementia risk, excessively low blood pressure, especially in older adults, might actually increase the risk for cognitive decline. And that's thought to potentially do that by reducing blood flow to the brain. And as I was mentioning, just like we care about our variability in terms of our glucose control, consistency also matters when we think about blood pressure control. The Lancet Commission reported that each unit increase in systolic variability of blood pressure was associated with an increased risk of dementia. And that was a pretty mild increase. Hazard ratios were somewhere between 1.02 and 1.1. So still matters, still impactful.
Yeah, so that's per unit, a sort of 2 to 10% increase. Did you say 1.1? Yeah. So, I mean, that can start to stack up if you're going up 5 or 10 units. What would you say is a systolic blood pressure that would be too low?
Yeah, it's a great question and something I don't have a perfect answer to. I think about it all the time. So, I'm somebody whose blood pressure is actually pretty low. My blood pressure is usually in the systolics of 90. I think if you're somebody who you usually ride around 120 and suddenly, with older age, your systolic blood pressure dropped into the 90s, that might signal a problem for you. Whereas if mine dipped down to the upper 80s, it may not be as problematic. So I think it's probably an individual framework in general, like targeting systolic blood pressure. I try to think like upper 90s to 120 is probably a good range for most people.
And what do you think about at-home testing, like getting like an Omron? I have no affiliation with that company. I just know they make a lot of blood pressure cuffs for upper arm or for wrist. Have you looked at that? Is this something that people could invest in? I think they're like $40 or $50. Is that a reliable test to be doing at home?
Yeah, as long as you calibrate your blood pressure cuff against a blood pressure cuff of your doctor's office or pharmacy, wherever you have something that's a very reliable metric for your blood pressure. I also don't have any disclosures about Omron or Withings, but I do think that those devices tend to be pretty reliable and things that people can purchase for a pretty affordable price. The thing is like consistency and how we're taking our blood pressure. So making sure that we're upright, making sure the blood cuff actually fits you. For people that are not the average size, you may have to invest in a smaller or larger blood pressure cuff that actually gets 80% of your upper arm in the cuff, not crossing your legs, trying to sit quietly while you take it. And then one thing that I really do ask patients to do when I'm trying to understand like what is their range for blood pressure is taking it in the morning and taking it in the evening, because there could be a lot of variability there. And it's really important to actually understand that, especially if, someone's high is in the 160s, but their low is maybe in the 110s. I've seen this. It's common in people who do have risk factors for neurodegenerative disease because of this autonomic dysregulation that can happen as a sequelae of neurodegenerative pathology. So it's something that we have to really be careful about.
Yeah, that's really helpful. So if someone is testing and they're consistently, say, above 130, and they think, I wonder, like, why do I have high blood pressure? What are the main drivers? Like, why are we seeing nearly 1 in 2 adults in America have, high blood pressure to varying degrees? What do you think is causing that?
I think there are lots of factors that could be causing it. Of course, obesity is probably one of the big drivers. Fortunately, now most people aren't smoking, but that definitely was a driver at one time. Alcohol use, another driver for high blood pressure, little physical activity. And then another one that, I think is often overlooked is stress. Like stress does increase our blood pressure, and as a nation, we're a pretty stressed out group of people. So it's something to just think about.
So when someone's in your clinic, you're presumably then trying to address those things. So if they're overweight, which we've discussed, if they're a heavy drinker, if they're smoking, if they're not exercising, if they're super stressed, so all of these kind of aspects of lifestyle, some pharmacology potentially for things like obesity. What about pharmacology drugs that directly lower blood pressure? Where are we at in that space, and how has that evolved? I know, like beta blockers are a very famous drug for lowering blood pressure. Are they the kind of drug of choice? Are they the best option for lowering blood pressure, or is it something else?
Yeah, so this is another area that's evolving in the space and something that I find very, very fascinating. So I'm always trying to read all the papers that come out on this topic. So what's the latest here is that angiotensin 2 stimulating antihypertensive drugs. So these are thiazides, non-hydropyridine calcium channel blockers, and angiotensin 1 receptor blockers may be the ones that convey a lower risk of dementia compared to angiotensin 2 inhibiting antihypertensives, which are ACE inhibitors, beta blockers, and non-hydropyridine calcium channel blockers. This is, again, an evolving area of research, but I do think that this is something that's going to pan out to be, there's going to be some truth behind this. I think that when we think about beta blockers, there's different permeability to the blood-brain barrier. These antihypertensives have different targets in the CNS. So whether or not they're reaching their targets in the central nervous system, whether or not they're crossing the blood-brain barrier, are probably all going to have an effect of whether or not these drugs can actually reduce the risk of dementia.
And in this case, are you thinking that crossing the blood-brain barrier is a good thing?
It could be a good thing for some people. It might be a bad thing for other people. It just depends. So, for example, I alluded to some patients that have very labile blood pressure control. I think beta blockers can be pretty harmful for these people because you are preventing their natural cardiac response to blood pressure drops, and they're probably more likely to dip out their blood pressure. What are their targets in the central nervous system with these beta blockers that penetrate the blood-brain barrier? I don't know if that's part of the mechanism behind why they may be more or less beneficial, question mark harmful. There actually have been some studies that, quote, said they may be harmful. I don't know. The jury's out there. But yeah.
Just remind us again, what were those 2 or 3 compounds that you said there's kind of emerging evidence that they might be superior for preventing dementia, these drugs that are lowering blood pressure?
Yeah, so thiazides, angiotensin 1 receptor blockers, so ARBs, and dihydropyridine calcium channel blockers.
Okay, cool. We can put that into the show notes.
One last thing on blood pressure is a question I get asked all the time. We talk a lot about systolic blood pressure, but what about diastolic blood pressure? Like, what should be my diastolic blood pressure target? And there was a study that was published in Neurology last month, September 2024, and they found that there is this U-shaped curve with systolic blood pressure, with both very low and very high blood pressure being linked to increased dementia risk. And they found that the lowest risk was like systolic blood pressure of around 80. So for all those people who are constantly asking, what should my diastolic target be? It should probably be around 80 millimeters of mercury.
So then putting that all together, earlier you said systolic, probably high 90s to 120. So we're thinking high 90s to 120 over 80. Is going to be a kind of optimal blood pressure somewhere in there, and then will be some variation between people. Is it true, while we're on blood pressure, that Black Americans tend to have higher blood pressure than white Americans? Have you come across that? And does that affect their risk of dementia?
So it probably does affect their risk. And yes, I have come across that. In general, cardiovascular risk factors are higher in Black Americans than in white Americans. And there's a multitude of reasons for why that may be the case. A lot of social issues that may explain why we see this. And it probably does impact their risk for dementia. One thing that, we often don't think about and really wasn't mentioned in the Lancet Commission is the impact of blood pressure on our kidney health or renal disease. And African Americans are at risk of kidney disease and seem to be disproportionately affected by cardiovascular risk factors in terms of their renal health. So it's just something to be aware of. Renal health does relate to brain health, and all of the downstream consequences of things like high blood pressure and diabetes in terms of what they do to our vision, our kidney health, and all other organ systems, our peripheral nervous system, probably all impact our risk, their propensity to cause dementia.
Okay, let's skip over to alcohol consumption. So excessive alcohol consumption was considered to be one of the 14 risk factors identified in this Lancet report. I think most people deep down understand that alcohol is probably not great for our health, at least in excess, especially brain health. But people like a glass of red, or they like a cocktail with friends, and they want to know what constitutes heavy alcohol consumption. What is excessive? Is there any safe limit of alcohol consumption when it comes to the health, the structure of our brain, and risk of neurodegeneration as we age?
So the Lancet Commission is defining excessive alcohol as around 12 standard US drinks per week. If you look at more individual studies, that number may change between men versus women, with women probably being considered consuming excessive amounts of alcohol with less, like around 8 drinks per week. But for the purposes of this discussion and what the Lancet Commission reports, we'll go with 12 drinks per week. That to me actually seems fairly high. I think that there's a lot of individual considerations here. So I bring up the ApoE4 gene again because it seems like ApoE4 carriers are disproportionately affected by the negative effects of alcohol. I am not a person that I can't say that I'm a completely sober person myself. I enjoy having an occasional alcoholic beverage with friends or with my husband. I think that there's something there in terms of the joy that it brings with social connectedness. I do recognize that it's completely a neurotoxin and that drinking late at night completely destroys my sleep. So I do take steps in my own life to mitigate the downstream effects of what potentially alcohol could be doing to my brain. But I also recognize that life is also about pleasure, and we all can't live in perfect isolation and not have some of these things that do bring us joy. If we're traveling and we want to experience a great glass of wine in France, I think that people should be able to do that without feeling complete guilt that they're going to cause dementia, even though I understand that ethanol is neurotoxic.
Right. So in the report, under 12 drinks per week was not associated with increased risk. It was only once you went over that threshold. Is that what they saw?
That's right, which seems high.
What do you think is the mechanism that would explain how alcohol is affecting the brain in a way that increases risk of developing this pathology we were talking about earlier that leads to dementia?
So I think there are lots of ways, but at the most basic sense of it, alcohol is a neurotoxin. And what neurologists commonly see in people who do drink excessively is that it's a cerebellar toxin. So the cerebellum is a part of the brain. It sits under our main brain. It's called the little brain. It impacts our balance, coordination. So when you do become intoxicated and, very intoxicated and you're stumbling and you're nauseous and you feel like the room's spinning, that's because it's impacting your cerebellum. We see that people that drink excessively have cerebellar atrophy preferentially, but we also recognize that alcohol impacts our memory center. It impacts our peripheral nerves. So there's probably lots of areas of the central nervous system that are directly impacted by the toxic effects of alcohol, but there are probably also downstream impacts of alcohol use. So, for example, alcohol impacts our sleep architecture. When we're sleeping and getting high quality sleep, going through REM sleep and deep sleep, that's our lymphatic system's most active time, and that's when we clear our brain of toxic proteins like amyloid and tau. So if we're drinking a lot, we're probably impacting our body's ability to kind of clear these proteins from our brains during sleep.
And I think I remember in the report reading that alcohol induced loss of consciousness. So this, idea of just drinking so much that we pass out is particularly bad for dementia risk.
Yes, I also read that. Absolutely. So drinking to the point where you pass out is very, very bad. Like, let's triple underline that one. It's very, very bad.
Right. So presumably then, the report said over 12 drinks a week is where you had increased risk. But if you have 10 drinks, which is under that, in one day and pass out, presumably that can't be great for your risk of dementia.
I think that there's probably some nuance in that it's also about binge drinking. So there's lots of literature on, the effects of just consuming a lot of drinks in one night could be even worse than 12 drinks per week. I think that needs to be sorted out a little bit more closely for brain health. I would assume that it's equally as bad.
I've heard some arguments out there that light drinking could be better than no drinking. What do you make of that? Is there perhaps a mechanism that could explain how small amount of exposure to alcohol is beneficial, or are we just looking for ways to kind of justify this behavior?
I think this is and you probably can speak even more intelligently about this, but this is such a area where there's so many biases in all of the studies that we look at. There's different selection biases, and it's so hard to isolate the strict effect of what alcohol is doing in an individual. I do think that the only thing that comes to me as like, how could alcohol be helpful, is not related to the alcohol itself. It's related to the potential social connections and social engagement that alcohol may be offering that may outweigh the risks of that one drink that you're having. But I can't even imagine a world whereby alcohol could be beneficial. I know some people have brought to me different studies on the benefits of antioxidants in red wine, and maybe it's that's helpful. And, I think there are lots of other ways to get antioxidants so that don't have neurotoxicity involved. So if it's truly for antioxidants, I think there are other methods.
Yeah, like you said, there are issues with some of the data. I've looked at a couple of studies where people have sent me where zero alcohol consumption seemed to carry a higher risk for dementia or mortality than light drinking. But then in the commentary, in the discussion, the authors were unsure as to, well, maybe the people that were zero drinkers at this time point had quit drinking because they had heavy alcohol consumption earlier in life, and it was very unclear. So I think what you just explained there makes perfect sense at this point until there's better evidence. What about other substances? While we're thinking about drugs, like party drugs, like cocaine and MDMA that people might be exposed to when they're out in kind of group settings, is there much information on how these drugs, party drugs, recreational drugs, that are often consumed in the same setting as alcohol, could increase risk of neurodegeneration?
So in particular, methamphetamines. So what methamphetamines do is they really cause your brain to release a lot of dopamine. And heavy methamphetamine use is actually linked to alpha-synuclein pathology or Parkinson's disease pathology. So that's one that, probably not the best to abuse. One that's more frequently used is marijuana, THC, and CBD. And what's really challenging about this area of research is there may be some actually neuroprotective effects of CBD or CBN, but it's really hard to separate that from the THC. And a lot of the studies that we're looking at are done in people who are smoking, because that was the most common way of consuming marijuana. And now that there are so many other methods, tinctures and edibles and lots of ways that people can access and consume THC, I think we have more opportunities to learn from this. In the short term, THC absolutely impacts your cognitive function. I think that there's definitely enough evidence to show that using it in adolescence while the brain is developing is also not good for mental health disorders, so higher risks of schizophrenia and probably higher risks of dementia later in life. But using it occasionally in adulthood, I don't know that we have any compelling evidence to say that it's long-term harmful for the brain. But again, I think we'll have more data on this now coming forth as more people have access to this, and we'll see more studies.
Which brings us to smoking, which was one of the other kind of main risk factors. And we mentioned that, perhaps a reduction in smoking of cigarettes at a population level helps explain why there is reduced individual risk of developing dementia, among other things. You mentioned better education. Talk to us about how smoking cigarettes, because I think it's still maybe 20% of adults smoke cigarettes or vape. So there's still a kind of high percentage of adults that are smoking. How does smoking affect someone's risk of developing dementia?
So, smoking, it's almost like diabetes in the sense of smoking is a multi-system disorder. It affects so many organ systems in our body. One notable one is it causes damage to our blood vessels, so vascular damage, which increases our risk of atherosclerosis. It can impair our blood flow to the brain. It causes oxidative stress and inflammation. And we have plenty of studies looking at brain volumes, MRI brain volumes in people who are smokers, and clearly shows that areas like the hippocampus are much smaller in people who use cigarettes.
Is there an exposure amount? So similar to how we were talking about standard drinks, it was more than 12 drinks a week, which carried the increased risk of dementia. Is there a certain number of packs of cigarettes per week that we know significantly increases risk?
I don't think that the Lancet specifically commented on the dose of cigarette use. It was just considered smoking versus non-smoking. And longer periods of exposure are worse, as most things are with the chronic issues. What I do think, and again, I don't think this was covered in the Lancet report, but at what point does smoking or stopping smoking, at what point do you neutralize your risk? Because we understand that once you quit smoking, your risk for dementia goes down, but does it ever go down to the level of a non-smoker? And if so, how long does that take? So it actually does seem like, as with other things like risk for lung cancer, that you really do eliminate your risk, and you can get it down to that of a non-smoker. And that takes probably on the order of 5 to 10 years. And that probably depends on how much smoking you were doing.
That's really positive news for a number of people if they're hearing that. That's actually that's quite amazing that so we talk about someone that maybe has smoked for 10 or 20 years. If they quit within maybe even just 5 years, their baseline risk for dementia goes back to that of a non-smoker.
Yes, which is really, really amazing. Just think about that. I know it's not easy to quit smoking if you are a smoker, but so much room for improvement, so much.
How do you feel about vaping? If someone's thinking, it's so hard to quit smoking, I've tried numerous times, but they can make that jump across to a vape successfully. Do you have any views on whether vaping carries the same risk or similar risk?
This is a really tricky conversation. And I have one particular patient who pushes me on this a lot, because as I've learned, there are different vape compositions, and some of them have different chemicals in them, and some of them are rather clean. The truth is, we just don't have very long-term data on this, and we're talking about a disease that happens over decades. So time will tell really whether or not, some of these more clean sources, it's pretty much just nicotine. Is that okay? Or does it matter what the composition of what's in what's in the vape matter? Probably, but at the end of the day, I think it's better. It's better than smoking cigarettes because we understand there are several neurotoxic compounds in tobacco smoke, but it's not something I would recommend doing.
And I think one of the kind of unintended consequences, at least what I've observed, is it's a little more socially acceptable. So you're seeing teenagers, obviously there's all these different flavors, so they taste great. It's acceptable, so people are able to do it in more locations. And so therefore your total kind of daily consumption might be much higher than it would be for smoking cigarettes.
And I think that it can't be overlooked that anything that you're inhaling is going to lead to some sort of inflammation. And systemic inflammation can cause neuroinflammation. So there's probably something there. Whether or not the effect is as pronounced as it is with cigarette smoking, jury's still out on that one. But yeah.
So as hard as it is, try and completely quit where possible. Thinking about inhaling substances, this brings us to, I think, the 14th risk factor. I'm pretty sure we've covered the other 13.
Think we did it, the marathon.
Which was air pollution. And so this was one on the list. I don't think it's actually going to come as that much of a surprise to people, but it's perhaps not something that we think about as regularly as we think about the food we're putting into our body or the exercise we're doing. We live in whatever location we live in, and it's kind of set or forget. How do we know if we're living in an area where air pollution is a problem? Is that something that we can measure?
So this is something I think for most people, when they see it as a risk factor, they kind of just like turn their heads because it feels like it should be a total public health issue. And how could, on an individual level, I do anything to protect myself about our air quality? But there are lots of ways that we can monitor our air quality outdoors. So I don't know about you, but my weather app on my phone gives me an air quality alert. So you're looking for an AQI, which is somewhere between 0 and 50. That's good air quality. When we do have poor air quality outside, avoiding going outside or avoiding exercise outdoors is probably something we could do to be protecting ourselves. And if you have to go outside, I know for my colleagues on the West Coast, there's been a lot more issues with forest fires. Using N95 masks when you have no choice but to go outside is one way that you can protect yourself from poor air quality. And just so everyone's on the same page, when we're talking about poor air quality, we're talking about particulate matter 2.5, which are these tiny tiny particles in the air that are very, very small, like 30 times smaller than the size of our hair. So really, really tiny. And what the studies have shown, what the Lancet Commission's reporting, is that for every 1 microgram per cubic meter increase of PM 2.5, your risk for dementia goes up by about 3%. So that's really, really high.
Yeah, and that idea of consulting your app before going for a run outside, that may sound really foreign to some people living in Western populations, but I can tell you I've spent a fair bit of time in Asian cities, and it's very common practice. It's just a routine part of their lifestyle to not just check how hot it's going to be tomorrow, but to also check the state of the air and then base your day and activity around that. I did a quick Google search. I was interested in what city in the world topped the list with the least air pollution, particulate matter. And at least according to the report that I found, it was Zurich in Switzerland, which doesn't surprise me.
Doesn't surprise me. Well, in the United States, I actually looked up which one had the best, which megacity had the best, and I was very surprised by this one. Miami.
Ooh.
Surprising.
Right. Severe weather recently, so a few things to kind of weigh up there, but
yeah.
We might all be moving to Miami or Switzerland. What? How do you feel? How do you feel about like at home filters? Are these effective at filtering out that particulate matter, that specific matter in the air that's increasing risk of dementia? And also I've seen different publications suggest it increases risk of cardiovascular disease as well.
Yeah, and Parkinson's disease. So yes, yes, yes. I think that if you live in a place where you're frequently succumb to poor air quality, I think investing in a HEPA air purifier is really a great thing to do. Also, just making sure that your HVAC system is updated and your filters are replaced. Really do your maintenance on that, because it's not just outdoor air pollution that we're talking about, it's also indoor air pollution. So protecting yourself by these small ways can probably have a big impact.
Yeah, and those are easy ones to kind of overlook. The HVAC systems in our house. In your email to me, you mentioned that we should also talk about environmental pollutants. Is there growing evidence that certain environmental toxins increase our risk of dementia? And if so, which ones would you kind of want to bring to people's attention?
Yeah, so this is another evolving area, and a lot of this comes from Parkinson's disease research and looking at epidemiological studies and different areas in the United States where Parkinson's disease risk is much higher than the general population. I'm not aware if the same has been done for dementia, but again, these diseases are all very related. And what's bad for the brain for Parkinson's is also probably bad for the brain for dementia. So I think it's really relevant here. And it seems like certain agricultural pesticides, herbicides, dry cleaning solvents are associated with Parkinson's disease. And there are certain belts, especially in the Midwest, where these chemicals are being used widespread with agriculture and farming. And we are exposed to those because we consume the foods that are being grown in these areas. So this is a thing that I really talk to patients about, really washing all of their produce really carefully. And if you do have the means to purchase foods that are grown, preferably in the United States, although we're not perfect, we're better than countries like Mexico with the types of pesticides and other toxins we're using in our produce, but preferably purchasing organic, or at least purchasing produce that comes from the United States, is probably your best bet. And of course, always washing everything before you eat it.
What about microplastics? Is there much data on microplastics and dementia and ways that we can kind of reduce our exposure to this?
Yeah, this is another area that I have to be honest, I haven't taken my own personal deep dive in. There is some evolving evidence, but I can't speak intellectually about it.
That's okay. We can come back to that. The other one that comes to mind here when I'm thinking about environmental toxins, people might be thinking about this, is heavy metals, particularly the consumption of fish. So my understanding of the literature is that consumption of fatty fish is typically associated with less risk of cognitive decline, dementia, even in people who seem to have more mercury found in their brain, which I thought was interesting. Do you have any kind of views on heavy metal exposure and dementia?
Yeah, so that study is, I think, so informative. So that study you're referring to looked post-autopsy, people's brain, even despite having higher levels of mercury because of their fatty fish consumption, they had lower levels of Alzheimer's disease pathology. I think that really does speak volumes. It is something of a concern. I think to what level we should be concerned is really debatable. If I had to theorize here, I would say that in adulthood, after the brain has developed, it's probably less of a concern. For women who are pregnant, probably more of a concern. Their baby's brain is doing important developmental processes. So that's something to really think about. And of course, for kids, while their brains are developing, maybe something more of a concern, but later in life, probably less of a concern.
Right. And then kind of thinking about that association that exists where increased fatty fish consumption is associated with less dementia. Do you think that is because of the DHA, which we spoke about in our previous episode? And so if someone was like, if we're thinking about kids or a pregnant woman and she's not eating, or they're not eating a lot of fatty fish, are they supplementing with DHA?
Yeah, there's prenatal supplements that can help with DHA. It's probably related to DHA, and I know it's not recommended to supplement with it, but if it were my body, I would do it.
What are your thoughts on heavy metal detoxes? Have you come across those online?
Oh, yes. Oh, yes, I have. I've come across this, and again, lots of things in terms of detoxifying from various environmental exposures like mold and all of that. And I think that it's individual on a case by case basis. I think you really have to weigh the risks and benefits. I've seen, and one thing that really breaks my heart is when I meet somebody and they're so desperate because they're so terrified by their risk and they're willing to spend so much money on lots of unproven things and lots of supplements, and they're really, really lost. I think that it's easy to become really entangled and go down really, really expensive, potentially scary medical interventions for a really unclear benefit. So before doing that, I think really thinking about all these risk factors that we've been talking about is definitely a better approach to reducing risk for dementia.
Do you think people should filter their water at home for drinking and the water they shower in?
Again, that depends on where you are in the United States. So looking back at that Parkinson's disease study, and there's a whole body of evidence on this too about well water, like how clean is our well water. It may be a problem for people that do have wells, and they may want to filter that because it is a reserve for various environmental toxins. In New York City, we are fortunate enough to have amazing tap water, but I understand that that's not everywhere. And it also probably depends not just on your city water supply or town water supply, your piping and where your plumbing, where your water's actually coming from. I think that it's something that's really low risk and potentially helpful, and a fan.
Okay, before we close this out, I want to just quickly touch on nutrition, sleep, and menopause, which were three kind of potential risk factors, or that I thought were potential risk factors that weren't included in the 14 risk factors, or at least not directly. So perhaps if we start with nutrition, which we've kind of spoken about a little bit here, and we only really need to touch on this at a high level. I was surprised that diet quality wasn't included in the model, especially given that it has an effect on LDL cholesterol and some effect on hypertension, obesity, diabetes, these other risk factors. What are your kind of just general views on dietary patterns and dementia prevention? And if someone was, wanting to look something up online, is there like a resource that you would recommend?
So I also was very surprised and disappointed that diet didn't make it into one of their modifiable risk factors, especially because of the overwhelming evidence. I think what's really tricky, and this is with a lot of these risk factors, it's hard to study dietary interventions, but there is a plethora of evidence that things like ultra processed foods are bad for brain health. And there's ample studies that support the Mediterranean and mind diet in terms of being associated with the lowest risk for cognitive decline. And honestly, Parkinson's too, dementia, Parkinson's, all of them. So I think that there is a brain healthy diet. And I think if someone really wants to learn more about what foods may benefit the brain most, they should read more about the mind diet.
Right. Okay, cool. I think that was Professor Martha Morris. I think she was the main kind of creator of the mind diet and researched various studies looking at how adherence to a mind diet affected risk of dementia. So that's a good resource. Look up the mind diet. And Martha Morris, I think, even has a book on that. What about supplements? We've kind of spoken about DHA. Are there any like known supplements or isolated nutrients that you would be like, yep, people should definitely be supplementing these to reduce their risk of dementia?
So there's no one supplement that I would recommend for everybody. And the Lancet Commission also does not recommend any supplements. That's not to say that I don't think that certain supplements can help somebody, the right person at the right time, at the right dose. So I'll just do a double click on, since we talked about omega-3s, I'll do a double click on B vitamins. I don't think that everyone needs to be supplementing B vitamins, but we do understand that B vitamins are so important for various neuronal processes, and that people with B12 deficiency, which may not even show up as deficiency based on some labs, have cognitive impairment, and it's a reversible cause of dementia. So B vitamins should really be optimized in everybody. And if you aren't, for various dietary reasons, if you're vegan or vegetarian, you may be low on B vitamins. So it might be something that's worth considering depending on your individual case. But at minimum, checking levels of B12, folate. I know people are like, well, no one's folate deficient. Yes, they are. I've seen it. And homocysteine can be really helpful.
Okay, so you just touched on homocysteine. That was my next question. So you're looking, like at blood work, you're looking at homocysteine and maybe some of these other markers like MMA, which I know a lot of people order that to get a deeper look at B12 than just kind of standard serum B12.
Yeah, and of course there are limitations with using homocysteine and various reasons for why someone might have elevated homocysteine that have nothing to do with B vitamins, but for a lot of people, elevated homocysteine is related to B vitamin deficiencies.
And elevated homocysteine, is that associated with increased risk of dementia? Is that something that if you see on a blood test, you're like, right, we're going to try and find out what the root cause of that is?
Yeah, there have been lots of studies looking at this, and homocysteine, high elevated levels of homocysteine are associated with brain atrophy on brain MRI, specifically in the temporal lobe. So another thing that we really think about, and whether that's the homocysteine itself or the homocysteine just a marker for other badness that's happening, we don't know the answer to that. But if it's something that we could correct with very low risk intervention, I think it's worth exploring.
Okay, so nutrition, to summarize, check out the mind diet. Look at that as just a kind of high level framework, and then individualize it to suit you. Optimize omega-3 index. Could we say that?
Yeah, so that's something I think we talked about with Tom.
Right. So that could be, and you could go back to our last episode with Dr. Dayspring, and I've had other episodes on that. That could be achieved through your diet or some combination of fatty fish and supplement. So there's different strategies depending on the individual there, and then specific supplementation after that, really just to be guided based on blood work and presentation. There's no magic supplement out there at the moment.
Unfortunately, we do not have a magic pill to prevent Alzheimer's disease.
Sleep was the other one that surprised me a little bit. I thought, insufficient sleep, or at least like working night shift and the disruption that has on circadian rhythm, I thought that maybe considered a significant risk factor for the development of dementia. What do we understand about sleep duration, quality, and how that's affecting our brain, and not only in the long term but also in the short term?
Yeah, this again, really surprising to me. And I think if it's not sleep duration that will end up being on this list of modifiable risk factors, it's sleep apnea, which will end up being on this list eventually. But just to go back to your question, I think what does sleep do for the brain? So there are lots of different sleep stages. And when we think about brain health, we spoke about this a little bit earlier on this episode, but during deep sleep, our brain's lymphatic system is activated, and that's our trash removal system. So things like having really high glucose levels in the brain, having amyloid proteins in the brain, all of that kind of gets detoxified or cleared from our brain during deep sleep. Various studies have showed that even after one single night of sleep deprivation, amyloid accumulation increases. So there's something happening in terms of our sleep architecture during deep sleep that's so crucial, but also REM sleep is really important. That's when all of our memories are consolidated. That's when we process what has happened to us throughout the day. That's when we can start to process emotional responses and behaviors. When we don't sleep, it's going to impact all these other risk factors. It's going to put you at an increased risk for depression and anxiety. It's going to predispose you to obesity or putting on visceral body fat. It's going to increase your blood pressure. So it's so hard to imagine a world where sleep is not an important modifiable risk factor for dementia. So hard to imagine.
Are there any like sleep hygiene practices that you think people should kind of prioritize to protect their brains? Like, what kind of conversations are you having in clinic about sleep?
So, sleep, understanding if someone is not sleeping, why they're not sleeping is really key. Understanding their sleep behaviors in terms of what their nighttime routine is. Are they a person that's waking up in the middle of the night to use the bathroom? Do they just have a really active mind? There are lots of reasons why someone may not be sleeping well. In a very niche population of people who may have preclinical disease, well, the preclinical dementia or Parkinson's disease could be impacting their sleep as well. I talked about this on one podcast, and I think I scared America, but I need to say it again because it's such a startling statistic that there are certain sleep behaviors that put people at risk for dementia later in life. Specifically Lewy body dementia and Parkinson's disease. And one of those things is called REM sleep behavior disorder. And this is when you're acting out your dreams, and it's not acting out your dreams, casually or just some sleep talking. This is like violent dream enactment with screaming and kicking and something that your bed partner would realize. And this isn't due to any other medications. All these things are eliminated. So certain pharmacological agents can put people at risk for this. But the positive predictive value for RBD for an eventual alpha-synuclein is greater than 90%. And that is wild. And this can happen decades before. So I think understanding that, there's something happening to our sleep architecture in these preclinical stages of disease, it needs to be better understood.
Is that condition treatable?
Is it treatable? It is treatable. Is it? Sometimes it's not always possible to eliminate the behavior, but there are definitely strategies that we can take for people to reduce the frequency of the events. But in my particular area of interest, why I focus on it is because people that have this are prime candidates for prevention. And I don't know exactly the ways to prevent. I'd be lying. Everyone would be lying to you to say that I know exactly what to do for someone who has this. I don't, but I'm willing to read and explore and understand this better because I understand these people are such high risk.
Sleep can be really frustrating for people to kind of workshop, and if you're someone that falls asleep, but then you're finding you're waking up and you're restless, tossing and turning from side to side, how does someone work out what's causing that insomnia? How do you kind of troubleshoot that?
So this is hard. We spend a lot of time talking about it. I have people keep sleep diaries. Sometimes I send people to CBTI, so cognitive behavioral therapy for insomnia. That can be really, really helpful. It's really about understanding and carefully thinking about you as an individual and what it is that is keeping you up at night.
And ruling out things presumably like sleep apnea.
Yes, ruling out sleep apnea, it's not even necessarily ruling it out, but understanding if it's that you're getting up to use the bathroom because you have an enlarged prostate. Is that what it is? Are you suffering from back pain and you're tossing and turning because you're uncomfortable? There are just so many potential culprits. But I would say that for most people, it's an active mind that keeps them up. And that's something that can be addressed.
So that might come back to stress. Will there be some overlap potentially with stress? So thinking about getting up in the middle of the night to pee, is that not normal? Like, what is normal? And how much of that is explained by kind of when your fluid intake is and if you're chugging heaps of water before bed versus something else?
Yeah. So, it's going to happen more as we get older. We'll wake up more to go to the bathroom. But if you're waking up more than 2 times in the middle of the night to go to the bathroom, it's probably something that needs to be looked at a little bit more closely. Of course, the timing of when your last beverages before bedtime is going to impact this. So trying to keep or not drink, if you do wake up in the middle of the night, trying not to drink 3 to 4 hours before bedtime is one strategy to just experiment with on your own. See if that helps. If it doesn't help, you probably need to talk to your doctor about why you keep waking up.
And is there, forgive me if you mentioned this, but is there a duration of sleep? Is it just the typical 7 to 8 hours of sleep recommendation that seems to be best for long-term cognitive health?
7 to 8 hours for most studies seems like a good target. Again, individual needs may vary, but 7 to 8 hours in general is what I try to have people shoot for.
And is that sleep or time in bed?
Yeah, good question. And this is hard for people who are tracking their data intensely. Sometimes the tracking of the data intensely does more harm than good. So that is time asleep, not time in bed. So if it takes you a half hour to fall asleep, you got to give yourself more time in bed.
Yeah, that's something that Whoop showed me. That my kind of 10 p.m., 6 a.m., I thought I was getting 8 hours every night, and quickly I learned that was not the case. Is there any data that you've seen on sleeping pills? So like benzodiazepines and risk of dementia, does taking a drug, let's say Valium, on the regular, is that going to negatively affect sleep architecture, brain physiology?
It seems like these drugs are harmful for long-term brain health. Again, studies on this are ridden with confounding variables because poor sleep itself is not great for brain health, but things like benzodiazepines, Ambien or Z hypnotics, and lots of over-the-counter drugs like Benadryl or diphenhydramine, Unison, all things that you can purchase to kind of help you sleep, are probably not great long-term for the brain. And it's probably various mechanisms that we're talking about here. So some of these drugs have anticholinergic activity, which is acetylcholine is a chemical that's very implicated in dementia, the disease process of dementia and Alzheimer's disease. So blocking that chemical is probably harmful for long-term brain health. So I could buy that these findings from epidemiological studies hold truth.
Yeah. And, just speaking personally here, I typically will sleep pretty well, but sometimes I will have insomnia. And if I'm completely honest with why I think I experience that, it's either not handling my stress well enough, so overactive mind when I wake up, or just my sleep hygiene just isn't what it should be. So I'm staring at a screen late at night. I'm doing work emails that are like, causing some low grade stress late at night when I should just be kind of tuning out and relaxing and unwinding. These kind of basic aspects of sleep hygiene that are so easy to kind of overlook.
Yep. That is, for most people, those are the exact culprits.
Let's finish on menopause. Is it true that women are at higher risk of developing dementia? And is that just because women tend to live longer, or is that related to menopause or something else?
So this is something that did surprise me in the Lancet paper, and I think something that we should really emphasize right now on this podcast, because I do think that there is a lot of misinformation in terms of what statistics are being thrown around. So I always hear this statistic that women are 2 times more likely to develop Alzheimer's disease or dementia than men, but that doesn't actually seem to be the right number. So women are at a higher risk for dementia. And I'm happy to be the one, for all those people who are listening, to tell you that it's not 2 times as high. So it seems like the hazard ratio is about 1.12, so about 12% higher, which is definitely real, and we are higher, but it's not as scary as 2 times higher.
And what do you think is explaining that increased risk?
Yeah, so there's a lot of talk on this, and the conclusions from the studies that I've seen are that even despite women living longer than men, it's not due to this increased age. Some of it may be due to, and hopefully this will change with time, less education for women and less cognitive stimulation due to them not working as much later in life. But it's also clear, and what I think the Lancet, what I'm most disappointed at in the Lancet, is that they really skimmed over this concept of menopause and the menopause transition and the benefits of estrogen for the female brain, especially given all that has been coming out with amazing researchers like Lisa Mosconi at Cornell, and all the work that she's been doing in terms of promoting women's brain health. I think that it's really an oversight and a disappointment that it's not being recognized as a potentially modifiable risk factor for women.
So at this stage, do we understand if menopause hormone therapy and what that hormone therapy looks like does lead to decreased risk of dementia? Is that established, or is that kind of something that's still to be studied and emerging?
We definitely need more studies in this area, but I think what is a little heartbreaking about it is that it's often dismissed because of poor quality studies. Studies looking at synthetic versions of estrogen and progesterone, and lots of confounding variables in studies that have carried on and have left doctors terrified of using hormones in patients, and even studies that have shown that dementia, HRT or hormone replacement therapy, may be linked to a higher risk of dementia. And when you really digest and look through the evidence, you just see that there's just this very clear deficit in our understanding of what could potentially benefit women and when. Some studies actually look at the timing of hormone replacement therapy and when to give it and who to give it to. And I think that there needs to be more research here. I think using hormone replacement therapy in the right woman in the perimenopausal window can be protective for the brain, but I don't think that it's fair for me to say that this is conclusive because there haven't been enough studies on it. And I think why I'm so disappointed by the Lancet is because they didn't give it enough of a highlight to make people want to study it in a really vigorous way. And I think that's just not the right approach here. I think women's brains age differently than men's brains, and I think they need their own dedicated research. And this is an area that is a huge potential target and something that we could definitely do something about. So it's just a little disappointing.
Well, if there's any young up-and-coming scientists listening that are looking for an area of science to kind of dig into and hopefully make a big difference, maybe that's one area they could focus on. With all of that in mind, so menopause hormone therapy aside, are there any extra preventive actions that women should take over and above all the things that we've already discussed?
I think that biological sex just needs to be considered in all of these risk factors differently. For example, when we think about exercise for women versus for men, is it different? It probably is. I think that these considerations, biological sex just needs to be considered when we individualize our treatment approach. I don't think there's anything specific that women need to be doing on top of men, but I do think that they need to be thought about in a meaningful way and have their own unique risk factors taken into consideration.
Perfect. I think this is a pretty good time to close this episode out. We're nearing on 3 hours.
Oh my gosh, a marathon.
Yeah, I knew that it wasn't going to be 90 minutes. Is there a final message that you would like to leave the listener with here?
I think that it's never too late to start thinking about your brain health. Of course, the earlier you start, the better. It would make me so happy to see 20 and 30-year-olds caring about this, but I also never want someone in their 40s, 50s, 60s, 70s, or 80s to be discouraged from taking steps today that could improve their brain health. So just understand it's never too late to start caring about this.
Right, and that brings us full circle back to the progression and the different stages we were talking about at the beginning. And even if reversal is not possible, which it could be, it does seem to be that adopting or addressing these risk factors can attenuate or slow down disease progression, which is going to ultimately lead to a higher quality of life. Thank you so much for spending this time with us again. We really, really appreciate all of the work that you're doing to shine a light on neurodegenerative diseases. Like you said, there's not enough light shown on these conditions, which affect not only the individual that we've spent a lot of time talking about, but they're affecting family and they're affecting friends and caregivers. So the work that you're doing is really, really powerful. Can you please remind people how they can find you online?
Yeah, so you can follow me on Instagram, Dr. Kellyann Niotis. I have a website, drkellyanniotis.com. Connect with me on LinkedIn. I love feedback. I love interesting questions. Nothing is too crazy for me to think about, and I appreciate everyone who cares so deeply about these conditions that are so close to me.
Thanks, Kellyann.
Thank you. Thank you so much, Simon.
There you have it, friends. I hope you enjoyed this episode. If you did and want to stay up to date with future episodes, be sure to hit that subscribe button on YouTube and follow on Apple or Spotify. Finally, thank you for showing up and the effort that you're making to take control of your health. I look forward to hanging out with you again in the next episode.